Do we have the recording going then?
I do, yes.
Okay, all right, then I think we're ready to go. Anybody missing that we should just wait for, or everyone here that needs to be here? Yeah? Yeah, okay. All right, well, welcome everyone. It's so nice to see all of our supporters here. My name is Deepa Rao. I'm the director of the MPH program in global health. And I'm very excited to launch our spring quarter thesis capstone and certificate capstone presentations today. We have a full lineup and a full 2 days of presentations, so it'll be really exciting to hear from everyone about the work that they've been doing over the last 2 years. This, for those of you who don't know, is a very exciting moment in our students' academic careers. It's a rite of passage of sorts. The thesis and the capstone are the crowning body of work that they've been working on with their MPH. They typically, our students go through a long series of courses that they take. They do practica, and then finally crown their time with us with the thesis and capstone. And you'll be hearing a small bit of their work today with their presentations. We're really excited to have you here. I know that our students wouldn't be able to do what they do without you, their supporters, peers, family, and we have a lot of faculty here who are who've supported them in their work as well. So thank you for being here. And for those of you who are presenting today, we very much recognize all the challenges that you've overcome in order to get here. Congrats to you for getting this far. Look how far you've come. We're really impressed. We're really excited to hear from you. I want to go through a bit of the structure, but before I do that, I wanted to thank Will Atienza and Zalamia Detta for organizing the presentations and helping us to kind of keep on time. So as you know, the presentations we're being recorded right now. Students, you have 10 minutes to present, and then we'll have 5 minutes for question and answer. Keep your ear out to listen for Will's voice, who will call out a 5-minute, 2-minute, and no time left warnings. There is a small clock on your display where you'll see how much time you have left, but because it's so small, we're also going to have a vocal call out around time at 5 minutes, 2 minutes, and when you have no time left. So if you notice you're running out of time, please adjust accordingly to stay within the 10-minute timeline. And if that means you just touching on a few slides, it's okay. And for the audience that's here, we'd ask that you submit your questions in the chat box, and we really encourage you to ask questions during that 5-minute time period. Doesn't matter who you are, if you're a parent or a student or, you know, a faculty member, it doesn't matter. We'd love to hear from you, and we'd love to see your questions in the chat box. I will read them off when the time is right. Let's see here. If we run out of time for the question and answer, the presenters will try to answer in the chat. And we'll move on to the next presentation. So with that, we'll get started. I just want to check in and make sure we're ready to go. Salam, we're ready to get started?
Yeah.
Okay. All right. Sounds good. So with that, I am very happy to introduce Frida Theophilus, who worked on a presentation, and her chair was Awa Kone, and the committee was Steve Gloy and Kashat Ronan. So we're really excited to hear your presentation. So you have the floor. And you're muted. You're muted. Oh, it's the mute button that we're looking to unmute you. And well, we're going to have to reset the clock.
Oh, no.
Okay. And we lost your presentation, but you did unmute for a second. Okay, got it. Your screen is showing, but you're still muted.
If you're having delays since you're presenting, you can close your video so that it helps with the connection while you're presenting.
There you go. I think we'll be.
Can you hear me now?
Can hear you, but your slide is gone.
Can you hear me?
Yes.
We can hear you. We can hear you. Your slide is gone. You need to put, oh, there we go. Okay, great. Perfect. Go ahead.
Am I muted? Am I muted?
No, you're
We
fine.
can hear you now.
Okay. I'm sorry for that. Good morning to you all. I'm new to my thesis presentation. My name is Frida Mboshono Theophilus, a Global Health MPH graduate, and I'm presenting from my home country, Namibia, in Africa. I'll be talking to you about my thesis, which is on prevalence of domestic and family violence reported by young Namibian men aged 18 to 24 years old. I have been working with Awa, Cassette, and Steve. I will walk us through background, study aim, method, result, discussion, strength, limitation, and conclusion sections. Violence against children is a widespread global health crisis associated with poor mental and physical health outcome. Approximately 1 billion children aged 2 to 17 years in Asia, Africa, and Northern America had experienced emotional, physical, and sexual violence in the past years. A 2013 comparative publication on specific country indicated that the prevalence of violence in sub-Saharan Africa among male victims aged 13 to 24 ranked from 29.5% in Nigeria to 51.5% in Malawi. And among female victims, the rate ranged from 15.3% in Zambia to 28.4% in Uganda. Our first study aim, we estimated the prevalence of childhood experience of the three types of violence occurring before 18 years of age among young Namibian men and 18 to 24 years old who participated in VAX Namibia. Our second aim was we estimated the prevalence of violence in the 12 months before the VAX survey among young Namibian men aged 18 to 24. I would like to define some VAX terms, but first let me explain what VAX is. VAX, Violence Against Children and Youth Survey, are a national representative survey of male and female aged 13 to 24 that are intended to measure the burden of sexual, physical, and emotional violence experienced in childhood, adolescent, and young adults. Currently, VAX is administered in 11 countries. And all the 11 countries in Africa, Asia, and Caribbean, VAX use the same definition for violence as per WHO and CDC. This was done to ensure to better comparison of the findings across the globe. For the purpose of this study, we talk about childhood experience of violence in the experience of young Namibian adult male, age 18 to 24, who experienced sexual, physical, and emotional violence before the age of 18. While childhood physical violence was defined as any experience of being physically forced with the potential to cause death, disability, injury, or harm. Childhood physical violence was defined as having ever experienced unwanted sexual touching, attempts for sex, present sex, physical forced sex, or alcohol facilitated and forced sex. Childhood emotional violence was defined as a pattern of verbal behavior over time or an isolated incident that is not developmentally appropriate or supportive, and that is a higher probability of damaging a child's mental health or his physical, mentally, spiritual, moral, or social development. Overlap of three types of violence among different forms of violence happen in two primary ways. Number one, violence could occur simultaneously, such as when a youth is being emotionally and physically subjected to violence at the same time. And or number two, violence could occur to the same youth but at a different point. Now, let's talk about methods. This is a second data analysis derived from the 2019 vaccine in Namibia, targeting youth Namibian male age 18 to 24. The sampling frame was originally compiled by Namibian Statistics Agency. In total, 3,472 primary sampling were sampled for both female and male using Namibia 2011 census master flame. In male PSU, 908 interviews were completed among 1,203 surveyed households. Let me tell you about my personality and my role in this project. I'm born in Namibia and lived in exile as an adolescent refugee in Cuba. I'm a proud Black woman living in my home country currently in Namibia. I'm a wife and a mother of three. During the 2019, Namibia was implemented. During 2019, when VAX was implemented, I was the Namibian responsible for sampling design, who also participated in protocol, weight calculation, and data collection. And that was my role in this project. Our study results show that 67.2% of participants were between the age of 20 to 24 years. With regard to education level, 11.7% has completed primary or less than primary, while 23.5% reported that they had completed secondary school and 15.3% had attended higher than secondary school. Around one-third of the respondents reported to have lost one or both parents before age 18. For a socio-economic condition, 55.3% reported to have experienced food insecurity. We found that approximately two-thirds reported experiencing some form of childhood violence before the age of 18, while some of the respondents experienced only one or two types of violence. A small number experienced all three types. All of those who experience only one type of violence, most 57.8% experience physical violence, followed by emotional with 35% and sexual with 17.6%. Among those who had experienced multiple types of violence, less than one-third reported two types, and a small number, 10.6%, reported to have experienced all three types. Findings from our study have shown that 46.3% experienced any violence in the past 12 months prior to the Namibian VAX survey. Among these two, 0.7% experienced sexual, 16% physical, and 3.4% experienced emotional violence. Moreover, among the respondents who reported to have experienced violence in the past 12 months prior to the study, 6.2% experienced two types of violence and 1.8% experienced all three types of violence. Now, let's discuss our findings. In this national representative survey of 557 Namibian male age 18 to 24, we analyzed childhood and contemporary experience of violence. We found that approximately two-thirds reported experience some form of childhood violence before the age of 18. While some of these respondents experienced only one or two types of violence, a small number experienced all three. Of those who experience one or two, or one type of children violence, most 57.8% experience physical violence, followed by emotional, 35%, and sexual violence with 17.6%. Among those who had experienced multiple type of violence, less than one-third reported two types, and small number, 10.6%, to have the three types. Our study findings are similar with previous reports from Kenya, indicated that 3/4 of adults experience some type of violence before the age of 18, with physical violence being the most reported type. Also, the 57.8% prevalence of childhood physical violence reported in our study were similar to estimates from a sub-Saharan Africa, a multi-country analysis on VAX, which found that 49.7% male of experienced physical violence. Our strengths. To our knowledge, the prevalence of domestic violence among young men reported in our study are the first reported estimate in Namibia. Our study is a sampling strategy that ensures that the data are nationally representative. Finally, our study used a core questionnaire that is inconsistent across country. So the findings are comparable with other similar studies. Our study have limitation also. It's a household-based survey. As a result, some vulnerable population might have been excluded or missed. This survey was done during school holiday. However, some children might have been missed, and children who had a severe disability or language barrier who could not understand responding to the interview questionnaire were also excluded. This survey was only focused on the prevalence of childhood violence among young men aged 18 to 24, excluding those who are aged 13 to 17. In conclusion, these findings of our study highlight the need for intervention to address the burden of childhood violence in Namibia. Future studies should address the burden of violence among this special study. Let me thank Gabriela, Jennifer, and Mark for their support in early time of my thesis. My appreciation goes to Cassette, Hour, and Steve for their effort, patience, time, trust, and understanding during my thesis writing process. Julie for her support, Edison for the support, Linda for welcoming me in Shiata, and my children, my mother and my friend for their unconditional support. And thank you for listening. Tangi Unene. Welcome all of you for your question and comment. Thank you.
Thank you, Frida. Great job. Wonderful. It was really nice to hear about your work that you've been working on for a long time. I will throw the first question out just to get us warmed up. But it's nice to see this wonderful body of work. I was going to say that it's a bit of a heavy topic, and you know, I'm wondering if you would reflect a little bit on what it was like to put this all together, given your own experiences that you disclosed in your positionality statement. Was it very difficult to work with this data, you know, given your own lived experience?
Yes and no, because that was the first study which I did, because I'm a statistician by professional, and that was the first study I did in health. So it was a little bit difficult because when we were conducting the survey, I was not really familiar with the definitions. But now, after when I'm now doing my thesis, it really opened my mind. I can say it was difficult, yes, but not really, because it really opened up and I become to understand more on domestic and violence in my country.
Thank you. So the floor is open for questions. It looks like we have a timer for questions too, huh? That's great. Now I can see
we have time for about one question.
Yeah. Okay, Steve, go ahead. Do you want to unmute and ask your question?
Yes. Great presentation, Frida. I was really impressed. The amount of violence was really quite high and kind of surprisingly high. What kind of reaction did the Ministry of Health or other sort of public agencies have in Namibia for the results of the study, and have any interventions been either planned or done?
Steve, I think you were cutting. Can you repeat the question, please?
Okay. Well, I was just mentioning that the proportion of young men who reported sexual or reported violence was very high. And what I'm wondering is, what was the reaction of the major stakeholders in Namibia, and have any interventions been planned or taken or conducted?
Yeah, there's a lot of reaction from my government, and there's a landline of childhood and childhood abuse by the police. There's also a project called Project Hope, which was done also. There's also a training was done by teachers and also the nurses, and just to see, like normally when you see that a person is abused, they have to react immediately and in a professional way. I think my country that is done a lot, but it's not really a lot, because when you see on the every day on the news, they just abuse children, abuse women, abuse men, mostly men. And I think there's also norms and belief which are also part of our culture, and it's preventing men to report. But the government is trying, but more need to be done in my country.
Okay. Yeah, thank you so much, Frida. It was really wonderful to hear your project and the answers to your questions, and congratulations. We'll move on
Thank
to
you.
the next presenter, who is Angel Chung, who will be presenting her certificate capstone, correct?
Yeah, that's right.
Okay, great. You have the floor.
Awesome. Okay, I'm gonna share my screen, and if my internet starts to cut in and out, please let me know and I'll turn off my video. All right. Okay. Okay, can everyone see my screen?
Yeah.
We can see.
Okay,
Go ahead.
awesome. Well, good morning, everyone. My name is Angel Chung, and I am a second-year Master's of Public Health student in the Department of Epidemiology, and I'm presenting in the Department of Global Health Injury and Violence Certificate Program. I'll be doing my presentation today on building demolitions and police-reported crime in Philadelphia during the years of 2013 to 2022. And before I start, I'd like to thank Dr. Steve Mooney and Dr. Ali Rohani with their help on this project, and the UW's Department of Epidemiology. So for my positionality, I wanted to mention where I stand on this project. I've had a long-standing interest in the public health field of injury and violence that's rooted in my own lived experience with violence growing up. And this informs the way I conduct my research and the way I hold myself in certain spaces. And as all of you may have gathered from the title, this work is being done in Philadelphia. I have no ties to the state, but my mentor, Dr. Steve Mooney, is doing built environment and injury and violence prevention work there, and he leverages his existing connections with UPenn and other Pennsylvania colleagues to do this work. And I just wanted to give a shout out to the data source that we're using. We're using Open Data Philly, and this is an open data repository for the city of Philadelphia, which tracks police reported crime and building demolitions alongside many other factors impacting the city. All right, so Philadelphia is located in the state of Pennsylvania. You can see the state is highlighted in red here, and is the most populous urban city as displayed by these two maps on the slide. And it's a post-industrial city, which means that there was a large boom in the manual labor and manufacturing jobs during around the late 18th and 19th century. But there has been a shift in economics that emphasize technology and finance, and the need for manufacturing jobs has decreased, and thus created an increase in factors such as suburbanization, urban disinvestment, vacant properties, and subsequent demolitions of those vacant properties. And so that leads us to the problem at hand, which is with the increase in vacant buildings during the post-industrial period that we've been in now, research has shown that vacant properties and crime have a large association, in which vacant properties may increase counts of urban crime. And so removing such buildings through demolitions or other forms of blight blight removal, along with other built environment interventions such as vacant block greening or abandoned housing interventions, have been largely associated with decreases in crime in other post-industrial cities such as Cleveland or Detroit. But some research has seen some opposing findings. And specifically in Philadelphia, many vacant properties are considered unsafe. So where we are now, little is known about building demolitions for properties that have been deemed as unsafe and its impact on crime in Philly. So that leads us to our natural line of questioning, which is how are we classifying safe versus unsafe buildings? And the Philadelphia Department of Licenses and Inspections are responsible for doing so. And they classified this as highlighted in purple, which is a building that endangers human life, the public welfare, has illegal or improper occupancy or inadequate maintenance. So knowing all of this, there is a gap in the literature around whether safety building demolitions influence the amount of crime in Philly. And this leads us to our first aim, which is we're investigating if buildings demolished for safety reasons are associated with any change in counts of police reported incidents within a 500-meter buffer of the demolition, as well as investigating if violent police reported crime specifically is related to safety building demolitions. So our methods, we are using Open Data Philly to collect our data, as I mentioned previously, and the data ranges from the dates collected on the screen. There are timeline differences that I would like to acknowledge just due to the way the department reports data and also the COVID-19 pandemic. And then this is a flow chart showing the buildings that we excluded from our study and why, and then our final study population is highlighted in red. I will skip going into this part in more depth just because of time. And then continuing on with my methods, the exposure of this study is whether a building was pre or post demolition. The outcome was all police reported crime incidents, and then specifically violent police reported crime incidents within a 500-meter buffer for each year in our study. For our analysis, we used a quasi-experimental linear mixed effects model, and we're specifically using a mixed effects model because it helps to account for the fixed effects, which is the average impact of our predictor, aka our exposure on our outcome, and then the random effect as well, which accounts for variability within groups, and that could be seen in the completed year of demolitions or each building in our data set itself as a unique of study. All right. And as I've alluded to previously, we're looking to define violent crime alongside all types of crime. And part of this involves conceptualizing the idea of violence. So the FBI's definition of violence is through the Uniform Crime Reporting definition, which includes murder, rape, robbery, and assault. But we're looking to use a non-UCR definition, which allows for a more expansive inclusion of violence and includes things like intimidation, threats, and harassment, because we know that things can be violent for people in different ways. And for our results, we found that the effect of safety building demolitions is strong. We see an overall average decrease in counts of all types of crime, all types of police reported crime incidents and violent police reported crime specifically compared to our baseline analysis. And we see that this effect is stronger for all types of crime compared to violent types of crime. And then on this slide here, I just have two figures which represent how many demolitions were included in our study through a line graph, and then where these demolitions were included or located on a map of Philly specifically. I talked a little bit about this blip due to COVID-19, but I can answer any questions about that later. And then for our discussion, overall, our data showed that safety demolitions may be associated with lower counts of police-reported crime in Philly, but there are several limitations to our study. We are only using police-reported crime incidents, and we do acknowledge that Philadelphia has a largely non-white population, and there are ties to historical mistrust of law enforcement, which may cause crime to be underreported. And we're also using a 500-meter buffer, and this is an arbitrary choice for the radius around building demolitions. And so future studies could seek to further understand how buffer size impacts counts of crime in areas around demolitions. And how does this relate to a global scale? This is for a global certificate. There are limited studies on the built environment and injury and violence interventions, and many of these are theoretical. So the studies that have been done on a micro scale have been shown to reduce types of crime, including burglary, robbery, and violent crimes, but this body of literature is not robust enough. And we cannot apply the findings that we've seen in US cities directly on a global scale because there are differences in characteristics of neighborhoods and historical context. So studying the spatial arrangement of the built environment and crime and its effect globally is important and should be studied further.
2 minutes.
And here's my references, and I can take any questions now. Thanks for listening.
Thank you, Angel. Great job. Really interesting study. It was really nice to hear your innovative approach to the work. So like before, I don't see any questions in the chat. So I will throw out the first question and encourage people to write their questions in the chat or raise your hand. There is one person who's right. Okay, since we have a little bit more time, maybe I'll just quickly ask my question. What are the next steps for this work, both for you and for the project? And then after that, I will call on Barakat. So, but if you would answer my question first, that'd be great.
Yeah, for sure. So next steps, I'm currently writing like a manuscript, trying to, publish this work. But we're also looking to incorporate maybe a more qualitative approach as well. And we have some colleagues on the ground in Philly, and we're maybe thinking of doing some qualitative interviews with the people living around these demolitions to kind of get a sense of whether they think that like the idea of safety has changed because of this intervention. So
Thank you. And then Barakat, would you like to unmute and ask your question?
Yes, thank you for the presentation. I appreciate it. One of my question is in terms of environmental concern. Some of the old buildings has asbestos or other environmental issue. How do they deal in terms of safety for the environment and for the people who live around that area? Have you ever done some studies?
so is your question, have there been studies that look at the environment like beyond buildings for the people who are living around that area, or am I misunderstanding?
Yes. Some of the old buildings has asbestos and other, hazardous incidents. What kind of protection?
Yeah, I'm not quite sure the specific protections that are provided in buildings that are safe for Philadelphia residents. I do know that a lot of the unsafe determination that the department does is whether or not, let's say, like the building is decaying, actually. So a lot of these buildings have physical structures that are like falling apart. And if you look on like Google or anything and you type up Philadelphia building demolitions, a lot of the residents in the area are talking about how like they're walking on the sidewalk and this building is just falling apart and it could fall on someone. So that's mainly what they're concerned about, like the actual infrastructure of the building. I'm not quite sure about whether like the presence of asbestos is classified as one of the main causes of like unsafe versus safe buildings, but that would be interesting to look into.
Okay.
Thank you.
Thank you. I hope I didn't miss it, but I didn't see anything in the chat in terms of another question. We do have a minute left. Any other questions? Okay, we did have a little extra time, I know. So yeah, so great job. Thank you, Angel, for
Yeah,
your
thank
work.
you.
Really interesting. And we'll move on to the next presenter. Our next presenter is Tiara Ranson, and her chair is our Dr. Wendy Barrington and her committee member, James Pfeiffer. So Tiara, if you're ready, you have the floor.
Awesome. Sounds good. Here, let me share screen. Can you see it in presentation mode?
Now we can, yes. Looks
Okay,
good.
awesome.
Mhm.
Okay, I'll start now. Hi, as you just said, my name is Tiara Ranson, and I am presenting my evaluation work with Public Health Seattle-King County's Institutional Accountability Tool. But before I start, I want to thank my chair, the amazing Dr. Wendy Barrington, my capstone committee member, Dr. James Pfeiffer, and project collaborator and soon-to-be Dr. Cynthia Parker. I work as a researcher for the Center of Anti-Racism and Community Health, who is in partnership with the county. And also, they're known by this acronym, and sometimes I'll refer to them as public health for short. And I acknowledge that although I am affected by racism as a Black woman, I am not a longstanding community member of Seattle. And instead, I provide my insight into this project as an evaluator. So with COVID unfolding, public health called a group together to represent community organizations across many sectors, including predominantly white, larger institutions, and then also smaller community-based organizations led by BIPOC individuals. The group provides consultation and recommendations to leaders of public health by giving them insight into community perspectives. And in March 2020, the advisory group slowed the spread of COVID by mobilizing urgent community mitigation strategies. So this graph in front of you here shows that progression. I don't know this. That's a little bit. This graphic shows the progression of the pandemic in Seattle-King County by race, where BIPOC communities had more instances of COVID than their white counterparts. You can see that in brown down here. So with this racial stratification and the murder of George Floyd, structural racism was declared a public health crisis, and the group shifted its purpose to cater to racial inequities, calling themselves the Pandemic and Anti-Racism Community Group, PARCAC. They shifted from leadership dominated by Public Health Seattle-King County to a co-led model with a steering committee centering voices of Black and Indigenous leaders. Now, post-pandemic, they're shifting their work to uphold institutional accountability across large institutions like public health, where they have developed a tool to follow the process of PARCAG's recommendations. And so these are my aims. For my evaluation work, we are understanding the tool and the process used to gather and track PARCAG's recommendations. We are evaluating how much the tool aligns with anti-racism principles and then highlighting places to further align that the connection between anti-racism and what PARCAG is doing. And so based on interviews specifically, this is the current process by which, to do this work, I'm conducting interviews and a document review where they are both analyzed deductively with rapid qualitative analysis, and then coded inductively using the public health critical race practice. And because of its application in academia and research and evaluation and in social justice work, we believe that this framework would be a great guide for analysis and for evaluation when it comes to aligning the tool to anti-racism principles. And so for this presentation, I focus on preliminary findings from the interviews here to draw connections between PARCAG's work and the praxis. And so you see, I spoke specifically with two institutional public health Seattle-King County staff members, 5 of those community leaders, the steering committee, and then 8 of the general PARCAG members. And so this here, what you see in front of you from these interviews is the current process by which recommendations are provided to public health by PARCAG, where the meetings are facilitated by, like I said, those community leaders, the steering committee. And what you see behind you there, that's the Excel document, that's the tool that they use. And it's a little complex and difficult to use. So there's a need for operationalizing how feedback is gathered, interpreted, and used. And based on the interviews, we noticed that the process being something that's sequential. So that's this like graphic in front in the dark purple. And so following those arrows, kind of reorienting a stepwise process will provide clarity to better set expectations for accountability with consistent communication and documentation. And so again, there's just this need for transparency in how ParkHag shapes decision-making, where like a tool usage must be reinforced.
5 minutes.
Thank you. So moving away from the recommendation process itself and highlighting an alignment to anti-racism principles, we can connect the current process, community perspectives, and positionality to 10 principles of the praxis. And so both ParkHag and the praxis move past documenting and noticing disparities, where instead they strive to eliminate them. So for today, I'll just focus on the 5 principles you see here. So starting with community voice, participant 4, they say that we've made the intent to have at least 60% of representatives of the steering committee, and also ParkHag overall, Black and Indigenous. So Public Health Seattle King County is really intentional with that 60% centering Black and Indigenous voices. And both voices are supported, but it's noted elsewhere that more Indigenous voices are needed. And so moving to the next practice principle, intersectionality. Participant 8 says that intersectionality of race, class, disability, housing is another piece that ParkHag can really bring when we're talking about things like the budget or services, things that are happening in the landscape. And so ParkHag is really intentional in incorporating intersectionality secondarily after Black and Indigenous voices. And so in general, we notice a need for recruitment strategies and meeting facilitation to 1, concretely center Black and Indigenous ideas, as well as also 2, incorporating the lived experiences that intersect with race, gender, sexuality, housing, disability. So this next piece here, critical approaches and addressing like primary racialization. Those are 2 principles. And so primary racialization highlights the social hierarchy in which socially constructed racial categories are manifested. And so participant 4 mentions a hierarchy of an institutional work environment that has the privilege to not usually respond to concerns of racial equity, potentially because there's a minimal BIPOC presence in larger institutions. And so they say that ParkHag members committed to racial equity that are from Black and Indigenous communities ask our departments about it. And that's where I think there's some of that healthy tension from our department having to respond. And so this individual does a great job of comparing the ParkHag environment to the and their values to the department of a predominantly white institution. And so using that healthy tension to call in individuals that are being held accountable to work against a racist system. And so that is a critical approach to racism, because it asks the department workers to understand their own biases and privilege in order to meet the concerns of ParkHag. And so lastly, this piece down here with feedback loops and addressing structural determinism. Structural determinism is the last principle that I'll be talking about. And it's a means of dismantling mechanisms that sustain racism. And so they say that staff who have the authority to make changes, also action and report back, this is what we envision. We have the tools in order, but we're still looking for the result. And so it's amazing that large institution leaders such as Public Health's chief financial officer, they ask ParkHag for recommendations, and the tool tracks their recommendations, but there's a need to go further with feedback loops that reconnect community members to institutional leaders to hold them accountable for those recommended changes. Like they're saying, we are still looking for the result. And so this here is kind of these observations from the last slide into something like a more tangible direction for the accountability process and sequentially the tool. And so this first piece here, it highlights the intentionality of centering Black and Indigenous voices in leadership, where the mostly BIPOC steering committee facilitates the meetings. And then this second piece here is added to the process, where we suggest that public health leaders connect with community during each meeting. And so recreating a structure that kind of situates community closely with institution, and it will dismantle that structural determinism that we were talking about. And then 3 and 4 together is that feedback loop, where at the top, public health reports back to ParkHag about the implemented recommendations, and then down below, ParkHag community leaders report these recommendations and institutional changes to their own community. And so that is it. Thank you so much for listening. I want to note that these are preliminary findings with more results to come, including finishing rapid qualitative analysis with those interviews and the documents, aggregating data, developing themes to guide that tool development, and then lastly, like kind of providing those recommendations to further align the accountability process with anti-racism principles of that praxis. That's it. I just wanted to thank my capstone committee, my family, my friends, you know, the Art Center team. I see y'all for all of your continual support. So I'm going to stop sharing if there's any questions.
Thank you, Tiara. Really nice presentation, really interesting work. I will throw out a first question. I'm curious if you notice tensions between the community group you're working with and like the academy and these concepts that come from the academy and the university. You know, like like you have very theoretical concepts in there, right? Like structural determinism and things like that. So I'm wondering if there were tensions there and then how you navigated through that.
Mm-hmm. I think this piece comes more in as like me being an evaluator. And this is what I was really excited for with this project because there is a gap. Like this praxis is something that we only use in institutions. And then like being able to be in community and noticing that, hey, community is doing the same exact thing, but there's different words. And there's that disconnect. I think that there's like tension, but as this like I think it said it in a quote, like it's healthy, it's good tension because I think that it'll push us forward because there needs to be like inclusion of community in large institutions. Like we see it in academia because we're so forward, but it's the same thing in public health. So yeah, I think thanks for bringing that up.
Yeah, and I would just comment that you're right. I mean, why do we create these like words when, why don't we just use the words everyone uses, right?
Mm-hmm. And gatekeeping because you need to have education to know those words. Like I'm reading my presentation, I'm like, I hope I said it right. I'm joking, but like those are thoughts.
Yeah. Well, thank you. And we have 3 minutes left for other questions. So I kind of looked through a little bit through the chat. I didn't see anything. Anybody have questions? I'd like to raise their hand and ask. Great. Janelle.
Hi, Tiara. So what would you say the next steps are for public health if you could have us um, make this a better process? What would you see us doing?
Mm-hmm. I think that it really is. I keep hearing over and over in the interviews about transparency and just coming back to community. So I think this tool is going to be really great because it'll just reinforce what's already being done. I think that y'all are doing some great work. It's just, it needs to trickle to other institutions. And then also, I think what really excited me was how there's leaders of public health coming to ask PARCAG. So I think showing their face and coming as a person rather than like, oh, I'm just going to do a poll. And I think that's already been happening too. So I just am excited to see more of it in other spaces.
Hey, thank you. I just want to say you did amazing work. Loved all the work you did at Public Health. So I want to give you your flowers while you're here. All right.
Thank
Bye.
you. Thank you, Janelle.
Great. Thanks for the question. James.
Really quickly, hi Tiara, great job, really well done. Just a quick question. I hope you don't mind me mentioning this, but you're interested in going to medical school, and I'm wondering what insights from this great work you might bring into, what are you anticipating you might bring into your medical training and how you will work as a doctor?
That's a good question, James. I think what I see like over and over in public health and like focusing on like determinants of health is that as paid, like thinking of the individual level of patients, like I'm really excited to be an advocate for a patient and helping them navigate systems. Even if that's, I mean, this sounds crazy, but eventually, even if it's not me being the physician, but figuring out like, what are your daily barriers, like in a more leadership role, like what are your daily barriers? Is it quality? Is it like a quality kind of control type metric? Is it like literal resources at the facility? I think that's kind of where I would hope to be. I noticed like this, I see the system in public health, and so I think it'd be really cool to be an individual advocate. And like as a doctor, you get to make final decisions for patients. And like I just want my patients to be like best supported and like know that there's actually someone who cares about them, who looks like them. Because I didn't get that. I didn't get that at all. Like it was really hard to find like my care team that's like down for me. And I just want to just be that person for them, like right off the rip. So yeah.
Well, I certainly want you to be my doctor. So
Thanks, Eva.
Well, congratulations and thank you for your presentation. I believe we're out of time. Please take a look at the chat comments. Lots of congrats. And I didn't see a question, but if there are any that come up, you know, if you could answer them in the chat, that'd be great.
Gotcha.
Yeah. Thank you so much.
Thank you so much.
Okay, so the next presenter is Sandra Urasaru, and your chair was Esso Olusegun-Soge, and the committee members Frederick Katira and Dr. Brandon Guthrie. So you have the floor. Let's see. And I can see your slide. Okay, great. Everything looks good on the slide front. So you have the floor.
All right. I hope you can hear me and see my slides well.
Yeah.
Greetings, everyone. My name is Sandra. Welcome to my thesis presentation on antibiotic use, variability across groups, prescribers, and prescribing habits in Rwanda. So a little bit on my positionality. I am Rwandan, college-educated woman with experience in health programs, and my role in the study while employed at IMB in 2021 included supporting the study setup, obtain approvals, and data collection safety processes, for which now my thesis is a secondary data analysis of collected data. Here are a few definitions to support shared understanding of the rest of the presentation. Bacterial AMR being the context of the discussion refers to bacteria no longer responding to antibiotics. And antimicrobial stewardship is this proven approach to promote prudent use of antibiotics. And the two tools that I list here are low-cost tools validated for use in assessing antibiotic use in hospital settings. All right, so we're all familiar with the great discovery of the first antibiotic in 1928. And shortly after that, in 1945, we learned about resistance. And to drive the message home, we care about antibiotic resistance because it's the ability, because of its ability to really affect care, treatment, and it has really well documented excruciating costs on patient and national levels. There is a huge body of literature on drivers of antibiotic resistance, and misuse and overuse tops the list. Hence the efforts to create low-cost, quick turnaround and accessible tools to contribute to surveillance, allowing early intervention, which is why the two tools I will discuss were used, one being point prevalence survey and an aware tool. Now, a relatively recent study in 2019 showed that bacterial AMR is like it has a huge burden, a striking burden, and in terms of direct death, 1.3 million people in the world died because of AMR, and about 5 million deaths were associated with AMR. Now, it's not a rare picture that the burden is disproportionately higher in sub-Saharan Africa, and Rwanda is located in sub-Saharan Africa. There is limited data in Rwanda on AMR burden, but the limited that's available shows this reduced susceptibility to commonly used agents and evidence of ESBL gram-negative increase. Now, ESBLs are extended spectrum beta-lactamase. These are enzymes I worry about because they confer resistance to a broad range of antibiotics. The study objective was to establish a descriptive profile of antibiotic use based on the WHO methodology and point prevalence survey, in addition to prescribing patterns of providers at the 3 hospitals that Partners in Health supports and accompanies in the care. The 2 aims are to describe proportion of antibiotic use, so frequency, classes, indications among hospitalized patients. And we also showed distribution according to the WARE classification. And we also aimed to characterize the antibiotic prescribing using a validated tool. The study is a cross-sectional study design, and it was conducted in 2021. We reviewed charts of 314 patients using the point prevalence survey. We included those that were antibiotics at the time of administering the survey and those who are admitted. For analysis, we conducted descriptive statistics and chi-square tests for relevant categorical variables and calculated prevalence of use using this data software. For providers, there were 51 providers who consented to participating in the questionnaire, trying to understand the rationale and scenarios were presented to understand their prescribing habits and tendencies. And also similarly, we had descriptive statistics and chi-square tests, and data is presented in proportions and frequencies of prescribing rationale. Now, in terms of findings, antibiotic use prevalence at the 3 facilities was 67.2%, and our respective antibiotic use at each facility presented is 72.8% at DGH, Currahee District Hospitals, and 56.6 at Butaro District Hospital and 73.3 at Greenwald District Hospital. In terms of age, median, the median was 10 and ACURA was 21.5. Majority of the patients were women at 59.5%, and common indications were neonatal infection and obstetric complication. And we can see C-section tops the list. In terms of department distribution, neonatology, OB/GYN, and pediatrics had higher prescription of antibiotics within those departments. And as far as facilities are concerned, Currahee had higher. Now, on the right side of your screen is number of diagnoses that were documented, and we can see that majority of the patients had about 1 to 2 diagnoses, and on the left are more indications that we found. We can see pneumonia being the 3rd. Here, I want to show the majority of patients had about 1 to 3 antibiotics, maximum being 5, and on average, patients had 2.1 drugs, which is slightly higher than the proxy recommended of 1.6 to 1.8 per encounter in WHO drug recommendation. In terms of antibiotics, the most common were ampicillin, gentamicin, and the 2 third-generation cephalosporin, cefotaxime, and ceftriaxone. On the left side of your screen, you can see that the classes like I just talked about, penicillin and 3rd-generation cephalosporin. It's important to note 50% plus or more were from the beta-lactam antibiotic group, which is cause for concern that I will talk about briefly in the discussion. And on the right side of the screen, we can also see that there's a corresponding antibiotic class, as I talked about, penicillin and 3rd-generation cephalosporin. But here I want to emphasize that 70% of the total prescription belong to the access group, which is in line with the WHO aware target of 60% proxy for national recommendation. Here, I share the WHO aware classification distribution, which is by total prescription per facility. And here I wanted to just point out how there's considerable use of watch antibiotic group at the Currahee District Hospital. And then on the right side of the screen, we have the highest use seen in departments of OB/GYN, internal medicine, and neonatology. On the provider side of the survey, here key findings point out that there is a larger young generalist pool of doctors with less than 1 year medical practice, and 70% were male providers. We see increased use of antibiotics, from the scenarios, one of which specifically was assessing situations of prescribing antibiotics before use of labs or getting lab results, of which the reasons range between reliance on signs and symptoms of infection or pre-op. Similarly, we have laboratory results delay as one of the reasons. Now, for recommendations and discussion here, it really is clear that the antibiotic therapy is a critical part of patient care at the 3 facilities, where 2 in 3 patients are prescribed antibiotics. There's variable use but higher than comparable settings. And the concern for beta-lactam group is because it's associated with increased selection or proliferation of antibiotic resistant strains. And these critical pathogens have been documented thoroughly, and that with increased resistance of Jackson, we've got to be careful. And then reliance on broad spectrum antibiotics, there is appropriate use. However, it's important to also kind of advocate for AMS teams so that there's continued use of prudent use of antibiotics. So AMS antimicrobial stewardship teams, where activities like training and guidelines would help encourage for better use. Now, similar to that, tailoring intervention to departments is important, just because we saw the different departments having higher use, like neonatology, pediatrics, and OBGYN. Here, most prescriptions were empirical without guidance of laboratory microbiology testing, so the need for improving lab capacity cannot go unsaved. Limitations, this is a cross-sectional study design, so we can't really talk about trends and over a period of time or use over a period of time. The samples are few facilities, and the chart review also has a limitation. Future research can focus on repeating PPS. Now, I cannot stop without thanking my team and the support of PIH. Special thank you, Fred and Elsa, for the chair, and the different facilities, and my family and the program. Thank you.
Thank you, Sandra. Very good job. Great presentation. It was so nice to hear about this. I don't see a question yet in the chat or a hand up, so I'll throw out the first question, which is, this particular study is out of my wheelhouse, as you probably know. So I'm going to ask you and maybe an interesting question, I don't know. But I know that Paul Farmer has been an inspiration to you in your wanting to go into global health, and now that you're a graduate with an MPH degree in global health, how do you think that his work inspired you with this study?
Deepa, can you hear me?
Yeah, I can hear you. I hope you heard my question.
I did not catch the last part of it. You were talking about Paul Farmer.
Yeah. How did Paul Farmer's work inspire you with this study?
I think for me, Paul Farmer has been impeccable, or a huge inspiration in my work for his drive for social justice. Also looking at no disease is beyond getting treatment for other reasons of, like, if someone cannot afford it, they can't get the care they need. So specialized care, however much we can make the case for health costs, is expensive. We can't get better antibiotics. We can't get world-class laboratory results to ensure like informed treatment and care. I think for me, the theme that he stood for and PIH stands for, where like all the effort that we can make and ensure patients get the care that they need, we have to make sure that works. So that's sort of the underlying inspiration for his work. Like no advanced disease, no advanced care, no advanced care is unreachable just because we don't have the funds or we're not able to care for them. So I think full rounded care is important, and this is one way to contribute to that in an area that's untapped in Rwanda.
Okay, thank you so much. I think Steve's hand went up first, and then there's 2 more hands and a question in the chat. Steve, why don't you ask your question, and then whatever we have time for, we'll see what we can do after that.
Okay, great presentation, Sandra. One of the biggest, if not the biggest, factors in antimicrobial resistance is antibiotics in animal feeds. Is that common in Rwanda, and to what extent are there efforts to change that?
So to that, I think it can fall well within the One Health approach towards AMR, combating AMR. Rwanda has put forward national action plan that incorporates both patient care and agricultural and also like animal related resistance. I do not have the data for how prevalent that is, but based off of the pace at which even within patient care it's not being tapped in, I doubt we have as much intervention, but I could look more into it for you and get back. Thank
Okay.
you.
We'll take one more question, and because Chantal Matoni's question came in first, I'm gonna read the question and then ask if Barakat and Loren can put their questions in the chat so that you can answer afterwards. But Chantal says, insightful study, Sandra, with the limited data on antibiotic use in Rwanda. This is such a great start. Can you expand on AMS implementation in Rwanda? Does it exist yet? At what levels? At which activities does that entail?
That's okay. Thank you for the question. So as far as antimicrobial resistance and AMS is concerned, Rwanda has had the National Action Plan in 2019. We also just recently got the AMS sort of guidelines for healthcare facilities in 2022. However, implementation is yet to take form. And it really, AMS being a multidisciplinary sort of approach, it requires just beyond the doctors being able to prescribe, but also pharmacists and microbiologists in the facility. More effort is yet to yield results for which we can speak about actual implementations of the guidelines, given the recentness of it. In terms of activities, there is governance structures, operation delivery, like reviewing formulary work, so formulary of medications, and definitely it has the Aware tool in it, which is great. So I think we're in the right direction, but that's kind of where we are in terms of we have the AMS guidelines set up right now.
Okay.
Thank you for the question.
Thank you, Sandra. And I saw Loren, you put your question in the chat. Sandra, if you could answer that in the chat. And then I asked Barakat if you could put your question in the chat, then Sandra can take a look and answer afterwards. We're going to move on to our next presenter. So thank you so much. Job well done. Really nice to hear about your work. I've been hearing little bits about over the years. So
Appreciate it.
Okay, our next presenter is Patience Jaman, and her chair is Ian Bennett and committee member Rabbi Yunusa. So Patience, we're excited to hear your presentation, and you have the floor.
Hey.
We can see your notes, so you'll have to put it in presentation mode.
Thank you, Deepa.
There you go. Oh, but we can see your notes still.
Yeah,
Can you swap displays on the, there we go.
this is good.
Yes, perfect.
Okay, thank you so much, Deepa. All right. Good morning. My name is Patience Jaman, and my presentation today is titled Enhancing Maternal Health Equity, Disseminating the Results of 2023 Washington State Maternal Mortality Review Panel Reported, the Legislature. My capstone chair is Dr. Ian Bennett, and my committee member is Dr. Rabbi Yunusa. Before I get into my project, I'd like to address my role and position in this work. As an immigrant from Ghana studying maternal mortality in the United States, I recognize that my perspective is shaped by my cultural background and academic inquiry. While I haven't personally experienced maternal mortality, I have worked as a physician and interacted with persons and families who have experienced maternal mortality, and I am committed to shedding light on this critical issue. In this project, I collaborated in collecting on-site primary data and participated in community partnered meetings. To the background, so the CDC reports that the rate of maternal mortality in the US is higher compared to other developed nations. According to the Maternal Mortality Review Panel report for Washington State, 80% of all pregnancy-related deaths identified were preventable. Additionally, the leading cause of pregnancy-related death was behavioral health conditions, predominantly from suicide and accidental overdose. So our project sought to assess the success and the limitation of this community-partnered effort to disseminate the report. And secondly, our efforts sought to elicit the community's knowledge of maternal mortality, which could be integrated into future community-centered interventions. Funded by the Washington State Department of Health, we engage clinics across rural areas of Washington State to raise the awareness of maternal mortality through the Maternal Mental Health Access Project in 2021 to 2022 through webinar series and learning collaborative efforts. This was successful. However, there was low participation, especially from Eastern and Central West Washington. This experience taught us that a new approach, that is a robust community-partnered methodology, was needed. So in 2022 to 2023, the Maternal Mortality Review Echo Session, which is a popular clinical case review approach, and the Across Washington convenings were started to provide direct training and to obtain feedback from community partners. This is where I joined the team on this collaborative studies and continued. Now, to describe our method, a prospective observational evaluation approach was used to assess the success and the limitation of this effort. The population studied included clinicians and community organizations that provide care to people during pregnancy and the year postpartum. Purposive sampling method was used to collect data through surveys and individual in-depth interviews. The qualitative data was analyzed using inductive and deductive coding in Atlas TI. Findings were then organized into resulting teams and illustrative quotes were highlighted. A community-based participatory research model was adopted in this project. So through a partnership process, we incorporated the context factors to elicit the community's knowledge about maternal mortality, and then to create a culture-centered intervention that would help us to obtain maternal equity. I like to mention that ethical principles such as autonomy, justice, non-malfeasance, beneficence were respected in this study design. Using the CBPR approach, we observe an overall increase in participation. 375 unique individuals attended one or more of the 10 echo sessions compared to 20 unique individuals who participated in the maternal mental health program in 2021 to 2022. There was also an increase in the number of organizations outside of King County participating in the project, especially clinics serving Indigenous, Native American communities and migrant farmers of Eastern Washington. We held listening sessions in 5 counties in the Across Washington project to learn the community's language around maternal mortality. It was an excellent time to hear how the community views maternal mortality and the gaps that must be addressed for them.
5 minutes.
Similarly, 75% of participants in the Across Washington community convenings were from outside King County. This for us was a success. To my thematic analysis. So this is a result of my thematic analysis. I'll go over just 2 of them for the sake of time. To begin with, we found it interesting that some providers who were part of the community were not surprised by the report that Native American women were 8.5 times at risk of maternal mortality compared to their white counterparts. This team highlights the complex interplay between insider and outsider perspective on maternal mortality. Having worked in the community, The participants possess intimate knowledge of the community's challenges, which contrasts with the experience of the outsiders. Insider perspective revealed nuances that outsiders may have missed. Their critical reflection underscores the urgency for change. The second theme was power dynamic, which reflects the exhaustion and the frustration experienced by marginalized individuals. It emphasizes the need for authentic representation and challenging existing norms about who holds knowledge and expertise. A participant said, and sometimes that's exhausting. Sometimes you walk into a room and they are just tired. They are tired of not being heard, and they are tired of not being acknowledged. They are tired of asking, why are you the expert? You don't even look like me. Why is there another white person turning to defend my hope and my future? Why isn't it my people? Why isn't it my people that look like me fighting for us? This team motivated the current phase of the project. From this evaluation, we recommend that fostering trust is necessary when working with historically marginalized communities. Secondly, we recommend that for whoever the researcher is, to be open and ready to adapt, as interventions may need to evolve quickly through a community-partnered process involving diverse communities. Lastly, community-partnered methodologies can significantly increase engagement and outreach to clinical and community-based providers. To end, my presentation today is not just an academic exercise, but a call to ensure that the health of every birth parent is safeguarded with the dignity and equity they deserve. I extend my sincere gratitude to my dedicated team members. I also acknowledge the individuals who died during or after pregnancy, the loved ones they left behind, and the people who cared for them. Finally, to my committee members who have become my mentors, thank you for helping me make the most out of my capstone. And to my husband, Isaac, thank you for always holding me up. These are my references. Thank you, and I'll take your questions.
Wow, Patience, that was wonderful. Great presentation. Really impressive project. I actually am quite moved. I really am.
Thank you.
Such important findings. My question to you to warm the discussion up is, what are the next steps? Like, how do we get this message out? It's so important for people to hear, people in power to hear. So what are your next steps?
Yes, so if you look at this timeline for intervention, the organization is currently here. So from February to September 2024, what my team will be doing is going out to the communities again to ask from them what do you want policymakers to do. And then we'll communicate that to the DOH, which we look forward to be communicated to policymakers. So that is what we are doing from now to September 2024.
Okay.
Yeah.
Yeah, and maybe we can talk about making more presentations to, folks in the healthcare industry and that sort of thing. So thank you so much.
Thank you, Deepa.
Other questions? I'm trying to see if there's anything in the chat. Lots of congratulations messages.
Thank you.
I see Amanda, you're unmuted. Do you have a question? Okay, muted. Great. Rabbi has a question.
Yeah, thank you, Patience, for that wonderful presentation. How was justice represented in your study? Because you outlined the ethical framework there. So how did justice show up in the context of that community and the work that you tried to do?
So for us, we realized that for the maternal mortality report that came out in 2023, the recommendations they had was not different from what they had presented in the previous years. They had just been worded differently. And so with regards to justice, we gave them the opportunity to speak up about, to speak up and be acknowledged for whatever is happening in their communities. And by giving them this empowering process of speaking up and organizing these events in their communities, we were able to like render to them justice, right? They were able to talk about how they feel about the situation, what they feel about the document that was released, and what they feel about the recommendation, what to them should be done. So that was how justice was applied in this work.
Thank you, Patience, for that answer.
Yeah. I know
Thank
we often get the question is how do we do social justice? And you've answered that question. So thank you.
Thank you, Deepa.
Any other questions? Oh, okay, well, we can move to the next presenter, but that was just so wonderful. Thank you so much, Patience.
Thank you, Deepa.
Yeah. Okay, so the next presenter is Timi Lynn Parade. Okay, I just wonder if someone was trying to get my attention, but I guess not. Your chair is Melissa Mugambi, and your committee member Aziza Musango. And thank you for presenting this body of work, and you have the floor. Yep, and I can see your slides, so I think we're good.
Thank you everyone for taking our time to be here today. And I am excited to be presenting this study, exploring the feasibility of pharmacy-based immunization for implementing typhoid conjugate vaccines in Nigeria, a global expert perspective. My position as a pharmacist of 3+ years in Nigeria, familiar with the Nigeria's community pharmacy landscape, informed the lens through which I approached my role in this study. My role in this study involved proposal writing, data collection, tool development, data collection itself, data analysis and interpretation, report writing, and dissemination. Typhoid fever is an acute generalized infection caused by a highly virulent and invasive enteric bacterium, Salmonella typhi. Data regarding the prevalence and incidence of typhoid in Nigeria is sparsely available, and this is due to a poor surveillance system. However, based on data that we have, the estimated burden of typhoid in Nigeria ranges from about 160,000 to about 490,000 cases per year. And then the estimated mortality ranges from about 6,000 to about 19,000 per year. Children younger than 15 years old and often bear the heaviest burden of typhoid. Typhoid conjugate vaccines are advantageous over earlier generations of typhoid vaccines. According to World Health, TCV has a high level of protection against typhoid from 6 months to 60 years of age. And Gavi provides support to countries for TCV vaccines from 6 months to under 15 years. However, in Nigeria, the expanded program on immunization primarily focuses on 0 to 2 years, leaving a significant gap in TCV provision for older age groups and other missed populations. And so thus exploring the roles that local pharmacies can play in providing TCV is essential. In this study, I adopted the COMBI framework, and I found it simplified, and the fact that it provides an evidence-based approach to understanding the target behavior. And this framework proposes that 3 components influence a target behavior: capability, motivation, and opportunity. Capability here means the ability to enact that behavior. Opportunity means the environment that promotes the behavior, and they all tie into motivation, which is the cognitive process that directs and inspires the behavior. And then they influence the target behavior, which in this case is pharmacists administering vaccines at community pharmacies. My research objectives were to explore experts' opinions on using community pharmacies as a setting for delivery of TCV vaccines, and to discover potential barriers and facilitators to adopting this strategy. I adopted an exploratory qualitative study design, purposive sampling of experts within nonprofit and academic research agencies that have dealt with implementing pharmacy-based or vaccine programs. Participants were identified based on supervisors' recommendations, literature review, professional platforms, and snowballing. For eligibility to be part of this study, you had to have had at least 4 years of experience with implementing pharmacy-based programs or vaccine implementation and be willing and able to provide consent. I also held semi-structured virtual interviews via Zoom from February to May 2024. Interviews were audio recorded and transcribed. I applied in vivo coding and thematic analysis to identify barriers and facilitators, and then I stratified by the COMBID domains, which I highlighted earlier on. Now to the results. I interviewed 12 experts, 7 men, 5 women, 8 were affiliated with nonprofits, 2 affiliated with universities, 2 affiliated with research organizations, and they all fell into the category of having 4 to 10 years of experience with implementing vaccines and programs in pharmacy setting, in lower resource settings too. Now to the results. I was able to stratify under the COMBI framework, and so the framework of capability poses the question, do pharmacy providers have the knowledge and skills to deliver this service? And experts felt that pharmacies receive vigorous and intensive training that makes them highly skilled healthcare professionals. They felt that pharmacists would, however, need training, just like any other professional that is going into an extended service, because their elementary training lacks that hands-on experience in vaccine administration. And so they felt that it's important to actually include training, certification, and they should also include components of vaccine administration, components of fundamentals of the disease, components of how to monitor AEFIs, and components on how to use M&E tools. Another barrier that was raised by the experts was that sometimes unskilled persons or quacks are left to manage these pharmacies in this area. And this is a quote from one of the experts that says, "It is assumed that a pharmacist is someone well-trained, but often, in some of these countries, they have nurses or anybody who can sit there and dispense medicines." Under the opportunity construct, it poses the question, does the environment support the delivery of this service? And so experts felt that community pharmacies may lack the space to administer these vaccines. And this is because they explained that the structure of the pharmacy in these areas are such that they're one-way traffic. You come in and you just pick your drugs and then you walk out. But then there will be need for space to actually sit, administer these vaccines, counsel, monitor for AFIs before they leave. And so space would be an issue. They also felt that professional resistance from other healthcare professionals would be a potential barrier. And they were of the feeling that for other healthcare professionals that are already involved in immunization may feel that pharmacies are taking over their job and by that feel threatened and oppose this service. They also felt that the community pharmacy is the first point of call. It's an untapped resource. It's a suitable environment for the administration of vaccines. And this was because they felt that the community loved them, the community trusts them, and it is important to harness that trust to the advantage of public health programs. And this was shared by one of the experts that says it's such an untapped resource in the community. Their position in terms of geographical location, proximity to which people can access them easily, their location in terms of customer friendliness is ideal. And the last construct of motivation poses the question, can pharmacy providers prioritize delivery? Do they have the desire to deliver this service? Experts were of the opinion that altruistic feeling that pharmacists would contribute to public health could be an initial drive. However, they expressed that the sustainability is essential to think about how strategic these incentives could be, because first of all, these businesses are privately owned. They may not want the government to come into their business. They are distrusting of the government, and also they would also want to tilt towards activities that are income generating. And so it is important to come to them with initiatives that will bring business growth for them to want to buy into the strategy. And this was shared by one of the experts that says, if they're done correctly, with so much private sector engagement. You can do anything with them. I mean, they're so creative. There's much potential there. If incentives are well aligned, they will do your public health function in a way that benefits the community.
2 minutes.
And so these recommendations are just from the experts that says adopt, that suggested that the program adopts a phased rollout approach that starts with adolescents and then moving on to younger age groups to incentivize pharmacists to participate through business development and growth ideas, to conduct research, to understand the community's attitudes and beliefs towards pharmacy-based typhoid vaccination. And this is because sometimes the community have a belief of what the traditional roles for each health worker, and they believe that to get a vaccine, I have to go to the clinic, while to get my drugs, I go to the pharmacy. And so how can that perspective be changed? Also to develop public-private partnerships to facilitate the adoption of the pharmacy-based typhoid vaccination. And conclusion, experts believe pharmacists can significantly increase vaccine coverage in Nigeria through this strategy. They feel also that implementing the pharmacy-based strategy is achievable, but focus should be on resource, policy, and incentive barriers. Further research and additional research with stakeholders is needed to fully explore the strategy's potential. I would like to acknowledge my thesis committee, Dr. Melissa Mugambi and Dr. Aziza Musongo, for their tremendous support on this. Their comments, feedbacks, and tutelage on this study has been tremendously helpful. I would like to acknowledge the funders of this study, which is the TIVAC project and the Vaccine Access team at PATH. And I would like to acknowledge others, which I highlighted below, who have been a pillar of support to me while on this journey. These are my references, and I would love to take your questions and comments right now.
Thank you, Timmy. Really nice presentation. I actually got a direct message question for you that I'm going to read out. It's from Rebi Yunusa, who is in transit, so couldn't raise her hand. EPI was discontinued in the 1980s and replaced by NPI. I'm curious why EPI was used for the study, because these have different goals.
Sorry.
And insider knowledge, I think, of the policies and programs. So she's asking about EPI being analyzed instead of NPI.
Okay, so I think that must have been an oversight based on my literature research, and I found out just about the EPI, but I think that that's a basis that I can do more research on. Thank you for that question.
Okay, and it looks like Steve, thank you, Timmy, and looks like Steve has his hand up.
Okay. Great presentation, Timmy. That was really interesting. I was blown away by how many deaths there are to typhoid in Nigeria alone. And so one of my questions is, is this, the vaccinations, you're saying the EPI program only does it from 0 to 2 years. Is it a standard immunization in the EPI? In other words, is everybody supposed to get it before they're 2 years old? And if so, why is the proportion of kids who get it low in Nigeria, or at least requiring pharmacies to do additional vaccinations?
Thank you for that question. So the EPI is like a standard schedule for vaccination of children. However, in that case, so there's normally campaigns at the clinics, and so children get their vaccination too at the clinics. But this covers only from the schedule accommodates just years from 0 to about 2 years, and so there are other populations that may miss that campaign, and so the amount of 0, I don't have the data off heart, but I know that there's a high amount of 0-dose children, because some people miss miss the campaign for different reasons. Also, the vaccine coverage in Nigeria has been pretty low, ranging from about 50 to 60%, and there are several factors with accessibility. There's factors of demographic, like maybe inaccessibility to clinics, cultural beliefs, vaccine hesitancy, and I think there are a whole lot of factors out there. And so we felt, or some of the rationale of this study is that why not bring it closer to them and make sure that accessibility is no more so much of a problem.
Great, thank you very much.
Thank you, Timmy. I think we have a time for one more question, but I don't see any hands up.
Yeah, sorry, we have about 3 more minutes.
Does anyone else have any other questions? Okay, well, we might be a bit ahead of schedule. Hopefully that doesn't cause any issues. Okay, well, thank you, Timmy. Thank you so much. What a wonderful presentation, and a lot, very clear, a lot of work went into this. So congratulations for being finished.
Thank you so much.
Yeah. Okay, so our next presenter is Diana Lalika. I want to pause because we're a couple of minutes early. Are your committee members here? Do you want to wait? You could take a...
I can see Anjali here. Yeah.
Okay. I thought I saw Irene coming on board too.
Yeah, I'm also here.
Okay, great. Then should we go ahead? You're okay with that?
Yeah, I'm okay.
Okay, so thank you. Next presenter, as I mentioned, Diana Lalika, and your committee members are both here and even vocally introduced themselves, Anjali Wagner and Irene Jaguna. So thank you so much. You have the floor. I can see your slides. I think we're good to go.
Okay, so good morning, everyone. Thank you all for coming today. My name is Diana Lalika. I am a MPH Global Health student, but also I'm in the Global Certificate program. And today I'm going to present my thesis, which is titled The Internet Hides Nothing, Kenyan Adolescent Experience with Sexual and Reproductive Health. So these are the things I'm going to highlight today. So for my positionality, I am East African born and raised. Hence, I'm somewhat familiar with cultural context in Kenya. And also being a graduate student at UW have empowered me with global health knowledge, as well as research skills, which were very instrumental in doing this study. And my roles in this project were data analysis in thesis, as well as dissemination of findings. So I'll start off by defining adolescence, which is a transitioning phase to adulthood and often characterized by various changes. And during this time, adolescents experiences varies with different factors, such as culture and more recently, digital media exposure. And so traditionally, adolescents have been facing challenges such as privacy and confidentiality concerns while seeking sexual and reproductive health information. And recently, digital platforms have been used to address some of these challenges. And so while digital platforms as a source of sexual and reproductive health information have helped empower adolescents in making informed decisions for their sexual health, it has also been a source of misinformation. And the overall impact of digital media still unclear. Hence, studies like these are very important to further explore this area. And with this study, I aimed at contrasting adolescents' experiences on different sources of sexual reproductive health information, as well as characterizing their recommendation for improving sexual and reproductive health information access in Kenya. And to do this, I collaborated with a team at Global Watch working on Sauti ya Vijana project, a project that employed respondent-driven sampling, as well as virtual focus group discussions to engage adolescents in Kenya. And so for my thesis, I mainly focused on the focus group discussions as they reflected the adolescents' experiences as they seek sexual reproductive health information. And this study was conducted at the Youth Center at Kenyatta National Hospital, as well as on Zoom and WhatsApp platforms. And the study included young people between 15 to 19 years who had access to smartphones, who were the only users of their WhatsApp accounts, and also who were willing to provide consent. And there are a total of 6 focus group discussions and 35 participants. So the Zoom sessions were audio recorded and then transcribed, while the WhatsApp texts were used as transcripts. So for analysis, we worked in a team of 5 researchers where we employed both deductive and inductive coding using deduce. And the deductive code book was created based on the questions guide, but then complemented by with inductive coding using data from the transcripts. And after coding, we developed code summaries, which were very useful in identifying the themes. And so here are the key themes I would like to highlight today. So the first theme is adolescents prefer digital media as a source of sexual and reproductive health information. And from the transcripts, we learned that adolescents rely on Google for sensitive topics such as sex. For example, one of the participants said, according to me, I support number 2 on Google. Since some people are good at judging others, they will think you have had sex. Because of that fear, and go to Mr. Google. And also, digital media provides anonymity and confidentiality to adolescents. For example, one of the participants said, I think they take advantage on going to Google because of fear. For my friends, they could ask me, but they're not sure if I'll keep a secret. If I feel I'm not safe giving my ideas or sharing my feelings with him, I'll decide to go to Google because I fear the confidentiality of the person. And lastly, adolescents actually believe that digital media provides comprehensive information. As one of the participants quoted saying, but nowadays the internet hides nothing. It will show you the details in full. The second theme is teachers and parents are not comfortable discussing romantic relationship and sex-related topics. For example, one of the participants said they could answer your questions on when you get periods, what you should do, and how to react. But questions concerning what is the right time to have a boyfriend they really avoided that topic. And our last theme is adolescents struggle with translating knowledge into actionable behaviors. And this is because the sexual and reproductive health information offered was largely theoretical with no practical examples. So for example, one of adolescents said, recalling an incident that occurred in class when one of their peers started menstruating in class, this person said, all of us had the teacher's concept and nobody was able to think outside the box. Instead of us telling her to use a different method to handle the mess, that's what we told her, laughs. We told her to visit the bathroom, take a shower, and then come back to class with the same clothes. So finally, our findings suggest that adolescents rely on online sources, especially on topics that teachers and parents are uncomfortable to discuss and on topics that their peers might judge them about. And also there is a need for comprehensive, demonstrative and inclusive sexual and reproductive health education, which calls attention to caregivers and teachers who are identified as some of the main sources, but not reliable when it comes to sensitive topics. And lastly, there is actually an urgent need to ensure digital literacy and safety in order to prevent misinformation. Just to point it out there, the recommendation for comprehensive and demonstrative and inclusive education came directly from adolescents themselves. Yeah, I would like to acknowledge adolescents who participated in the studies, the caregivers who supported them, and also my thesis committee. Thank you so much, Angelo, Agna, and Irene Juguna. You guys were really instrumental in doing this. And the funders and organizations that contributed to this project, the research team, and my family. I can see Matthias and Faria there. Thank you so much, guys. Yeah, and those were my references. Asante sana. I would like to take questions and feedback.
Great presentation, Diana. Thank you so much. Let's see. Trying to see if there's any questions in the chat. I don't see anything yet. So my first question warm-up is, what are the next steps for this work? Is there any way to get these findings back to parents or members of the community that you worked with for this study? Just curious.
So we have not done that yet, but so this part is part of South Yabijana project, and I hope those will be the next steps. And most especially, I would personally love to insist on the digital literacy area, because it looks like adolescents are increasingly rely on online sources, and with online sources they come with a lot of misinformation, misconception, myth. So it's important to actually help them to actually know how to get appropriate information from the internet, and also encourage parents and teachers to give them the support they need.
Okay, thank you. Other folks that have questions, please either raise your hand or write your question in the chat. Lots of congratulations coming in. Okay, well, we can move on.
Yeah, we are quite a bit ahead of schedule. We have about 5 extra minutes, so we could either start the next presentation early or take a 3-minute break.
Well, I wouldn't take a break just because we have our lunch break right after that.
We do.
So that's why. But let's see. Okay, so thank you so much, Diana, for your presentation. I wanted to acknowledge that you're done before we move on to the next steps and the next presenter. So great job.
Yeah, thank you, Deepa.
Okay, so let's just see. Lydia, are you on? Lydia Bokonde is our next presenter.
Yes, I'm here.
Okay, and would you like to go early? It's almost a whole 5 minutes early. Are your committee members here, or are those that you expected to come join us? Are they here?
Yes, they are there. James and Richard.
Okay, well, if we're okay with that, then if you're okay with it, we'll go ahead.
Yes.
Okay, so as you mentioned, Lydia, the chair is Rachel Chapman and the committee member, James Pfeiffer. So we are looking forward to your presentation, and you have the floor.
Thank you. Hi, everybody. My name is Lydia. Thank you for this opportunity, and I'm really excited to present my thesis on improving perinatal care among women of African descent and through home blood pressure self-monitoring in Seattle. So for my positionality, I am a female of African descent born in Congo with a medical background and personal experience with pregnancy. I've been also part of the research team, and I participated in several steps for the research, including designing questionnaire for interview and data collection and analysis. So let's talk about the background. So the US has the high adverse perinatal outcome compared to other developed nations. However, the rates of maternal mortality for Black population is very high when compared to other races. And preeclampsia is the leading cause of this maternal mortality. In addition to this disparity in Seattle, perinatal health insurance doesn't cover blood pressure cuff. So for my thesis, I work with the Heart, Soul, and Joyce project, which is a maternal wellness project. So the goal is to prevent perinatal health disparity among BioPOR patients in federally health and reserve area in Seattle. So the project objectives are to document provider patient acceptance and the use of technology, and then also to assess the benefits and challenges of using that technology. So for my thesis, the objective is to identify the core benefits and barrier for perinatal home blood pressure, screening among African descent, women of African descent in Seattle. For the sampling, the total population recruited by clinic staff and who fit the criteria for inclusion of being pregnant patient. For our frame population was all pregnant women who sought an antenatal care service in 2 community health clinic system in Seattle. For our inclusion criteria, they were all the same patient, but those who did not have previously blood pressure at home, those who agreed to participate in our study and then also receive the blood pressure cuff. So for the data collection and analysis, survey data were entered into Survey Planet, and we exported narrative data into Word document and applied an active coding approach for analysis. And for the funding, it showed that blood pressure cuff increased self-efficacy. And we define self-efficacy as the confident participant has to trust their feeling to accomplish desired outcome. So participants reported that blood pressure changed their feeling, and which changed feeling lead them to make informed decision and take action. When they felt in need, they were confident to get their blood pressure cuff and use it. So reading the participant quote, having the blood pressure cuff and the screening tool made me more aware of monitoring my blood pressure. When I feel under the weather or possibly have a headache, I immediately check my blood pressure. It made me more conscious and aware of blood pressure. So if I'm ever feeling down, I will check my blood pressure. Second, we found care-seeking behavior as a result of self-efficacy, especially for those who experience high blood pressure. So patients report that they immediately check their provider when their blood pressure went high. So reading the quote again, I'm not sure, I just took it, it was high, it was in the yellow zone. I think I was overwhelmed that day. I did the same procedure again. I called and they told me to wait 30 minutes. And it didn't stay the same. It went down to the green area. I called and we took it 30 minutes later and it went down. Another finding of the blood pressure is that it creates more point of contact. It's another timely provision and also provider follow-up. So patients, this is the first. So patients with high blood pressure thought and care as they needed. They didn't wait to contact their provider only on their regular visit or appointment, which in turn increase more point of contact and also lead provider to promptly provide care to their patient. In this one also in turn lead provider to follow up on their patient. So reading the quote, I called the hospital and I was referred to the clinic and medication dosage was changed. Here is the report's percentage of care seeking and care provision. Of the total of 52 women of African descent who complete the intake midway and exit survey, 20% of them experience high blood pressure, and all of them, or 100%, also receive thoughts and receive care. They were also followed up by their provider. So as we anticipate the model, women like the blood pressure intervention. When they use it, they get more somatic information, which increase self-agency, self-efficacy, and in turn promote care seeking, and then also increase patient-provider contact. So through this cascade, we also identify a new step in the care flow. increased care seeking results in increased patient provider point of contact, also improve timely provider intervention and caregiving, enable provider follow-up, and then also patient follow-through. This also could lead and could potentially prevent a health crisis. So giving this cascade of care-seeking, patient more point of contact, and timely provision, we think that this could actually lead to a better care. This could actually lead to a better care, and which could potentially contribute to lower maternal mortality due to preeclampsia, and then also reduce the perinatal race, ethnicity, health disparity among our community. So we think that universal provision of blood pressure cuff is the great tool to intercept the high volume of undetected high blood pressure among our marginalized population. So I would like to thank you as my thesis committee, Rachel and James, and then also the whole research team as well. So thank you for listening, and I'm ready to receive any comment and question.
Hey, great job, Lydia. Thank you so much. I'm just going to take a pause to see if anyone has questions. I'm happy to throw out a question, but let's see if anyone in the audience has a question. Great, Rachel.
It's not a question. I just want to say I'm so proud of you, Lydia, and so excited to see you presenting these findings. I couldn't be more proud and honored to have you on the team. Well done.
Thank you.
Yay. Lots of similar remarks in the chat. You'll take a look when you're done. Amazing work. I will throw out a question since we don't have one yet. And my question is mainly, I know with home blood pressure cuffs, there's a lot of variability in readings. Did that come up as a challenge or in your work?
Yeah, it was one of the challenge. So the most challenge was about the technology, how to use it. Most of them, they were receiving like a inaccurate reading. Maybe it was about the battery or the cuff was too small to fit on their arm. Yeah, that was the most concern about that.
Oh, interesting. And I wonder if your team is able to give feedback to, the makers of the cuff that, perhaps they're not able to, maybe their mechanism isn't appropriate, and they could make some edits or changes to the design.
I think, yeah, that is a suggestion I'm gonna tell them so they can improve it. Yeah, but it was just a few of them. No, I think I got only 3 people who was concerned about especially about the size of the cuff. It was too small. Yeah, other than that, it was no big challenge of using it.
Mm-hmm. Well, really important work. Thank you so much. Okay. Any other questions? Oh, James, go ahead.
Well, in the absence of any other hands going up, just congratulations, Lydia. Brilliant work, and what a joy it's been to work with you on all of this. But this is more in the way of a shout out to Lydia, that many of you know that there have been a number of refugees camped at the Tukwila Church. Many of them identify as Angolan, but actually have Congolese background. And Lydia and Rachel have been working with some of them who showed up in the sample for prenatal care. And Lydia was translating with many who speak the language that Lydia is fluent in. So Lydia was going above and beyond the duty to support these very, very vulnerable folks that had showed up in our community and weren't getting much support. So hats off to Lydia for taking that on.
Thank you.
Thank you.
It's important to note that. Sometimes it does take going above and beyond to really reach people, and it's okay to do that. Some people feel like we can't, but thank you. Okay, any other questions? We're ready to let Lydia off the hook.
Thank you.
Great job. Wonderful
Thank you so much.
presentation and body of work. Thank you for all of your efforts. All the presentations this morning have been so wonderful. Thank you all for attending. We now have about 1 hour lunch break. So if you're attending the afternoon sessions, join us back at noon. We'll begin at 12:05. If you're a presenter, you might want to join us around noon and kind of see if we can get you set up early. But nice job, everybody, so far. Really excited to hear about everybody's work, all the things you've been working on for so long. So thank you so much. We'll see you all at noon. Thank you for joining us. We are now beginning the second half of day 1 presentations of Thesis and Capstone. In the morning, I gave a more elongated welcome, but I do want to welcome all of you and thank you for supporting our students and for being here today. The students just really quick have 10 minutes to present. They have a timer, but will audibly give some time markings, and we have 5 minutes for Q&A. And there's a little clock that the presenters might be able to see if they look to see how much time they have left. I mean, though it's hard to see and it's very small. But we invite everyone, whether you're a faculty or a family member or a student, to ask questions. You can put your questions in the chat or you could raise your hand, either way. So we welcome a nice, robust discussion. Our first presenter for the afternoon session is Susan Glenn, and her chair is Mary Kernick, and her committee members are Ariana Means and Susan Thompson. So thank you, everybody. And Susan, you have the floor.
Thank you. Let me share my screen. One second, sorry. Okay, can you guys see the PowerPoint?
We can now see it. We can see it in presentation view. So I think it looks good.
Okay, great. I was like, not the notes, right?
No, for a second there, it zoomed out, but then we can see the full presentation now. Go
Okay,
ahead.
great. Thank you. All right, thank you all for being here. My name is Susan Glenn, and I'll be presenting my thesis, an evaluation of a gender-based violence training for health providers in Timor-Leste. Special thanks to my thesis chair, Dr. Mary Kernick, and my committee members, Dr. Ariana Means and Susan Thompson. Before I begin, I want to give credit to the HMNASA team in Timor-Leste who did the hard work to plan and implement this training, and they collected all the data that I'll be presenting on today. For a bit of context, gender-based violence, which I'll refer to as GBV in this presentation, is harm brought upon individuals based on their gender and includes but is not limited to domestic violence, sexual assault, and child abuse. In this presentation, I'll largely be speaking about male-perpetrated GBV against women, though I acknowledge that's certainly not the only kind of GBV. Timor-Leste is a small country in Southeast Asia located in the lower right-hand corner of this map, and is in the top 14 countries for incidence of GBV in the world, with between 35 and 59% of women in Timor-Leste experiencing GBV during their lifetimes. Beyond being a human rights issue, GBV has well-known health impacts. In Timor-Leste specifically, women who experience GBV are more likely to be infected with HIV, be depressed, have STIs, attend fewer antenatal care visits, and are more likely to have one or more of their children die compared to women who do not experience GBV. And so given the depth of this problem in Timor-Leste, the government passed a law in 2010 outlawing domestic violence and followed that with a 2012 National Action Plan addressing GBV across sectors in Timor-Leste. Despite this prioritization of GBV, however, particularly in the health system, few health providers have received training on how to respond to GBV. So in line with both the government's prioritization of reducing GBV in the country and the need for health provider training, a local NGO, HMNASA, formerly Health Alliance International, implemented a USAID-funded health provider training model in partnership with the Ministry of Health, the Ministry of Social Solidarity and Inclusion, and the National Institute of Health. which aimed to educate health providers in GBV dynamics with the future intent of providing better care and protection for victims. The training consisted of an initial 5-day training beginning in July 2021, followed by 14 months of monthly learning labs, which were where trainers visited the health facilities monthly and refreshed provider knowledge of the GBV modules covered in the initial training. This training was conducted in 11 facilities in Lakisa and Aramera municipalities, which border the capital of Dili and have some of the highest rates of GBV in Timor-Leste, with just under 60% of women experiencing GBV in their lifetimes. This research had 2 aims. The first was to assess change in individual health provider knowledge, attitudes, empathy, system support, and confidence in responding to GBV before, during, and after participation in the training. And the second was to assess the additional contribution of learning lab attendance as a predictor of changes in score across domains. The majority of this presentation will focus on that first aim due to time, however. The study was a pre, mid, post intervention design with no comparison group in 11 facilities. The INS Human Research Ethics Committee in Timor-Leste approved the project, and UW-IRB granted a non-research determination. I utilized data collected via paper-based surveys administered at the 3 time points: baseline, post-intensive training, and 14-month end line, and participants were assigned participant IDs to track them over time. And only those who completed 3 surveys were included in the analysis. Statistical analysis was performed in RN's data with significance set at 0.05. In line with best practices for limiting bias, multiple imputation was used for missing baseline and outcome responses, and I performed t-tests and ordinary least squares linear regression to address the research aims. The surveys we used collected data on 5 domains: healthcare provider knowledge, attitudes, confidence, empathy, and perceptions of system support as they relate to GBV, and the analysis was done separately for each of these domains. Before I present the results, it's important to acknowledge my own positionality within this research. While I have visited Timor-Leste for business, I'm a white American woman and I don't share the same background or context as the health providers in Timor-Leste who received this training or the HMNASA team who implemented the training. I'm really grateful for the mentorship of the HMNASA team, in particular the director of M&E, Amir, who's shown me such grace and support in this work. I've benefited greatly from the mentorship of my thesis committee and my mentor, Jessica Dyer, who provided coding support.
5 minutes.
So, of the 459 individual surveys completed across the 3 time points, 43 did not consent to research and were excluded from the analysis, and 182 surveys could not be matched. That resulted in 234 surveys that I was able to match across the time points, and which equated to 78 individuals in the final sample. The final sample was a majority female. Over half were under the age of 35. And professionally, the group had a fairly even spread of doctors, nurses, and midwives, with few community health workers and other professions. And that other profession group included pharmacists, lab workers, public health officers, and facility managers. Using t-tests to assess for significant differences, statistically significant differences were observed from baseline to post-intensive across all 5 domains, but there was this clear plateauing of scores between the post-intensive training and the 14-month end line, as you can see here. To further investigate the period between the intensive training and end line, I utilized linear regression. In the unadjusted estimates, knowledge, confidence, and empathy had significant results, but once we adjusted the model for baseline score, sex, age group, position, and attendance at learning labs, those p-values were outside of the 0.05 significance level and were marginally significant, as you can see here. So what do these results mean? The training overall worked across all 5 domains. We saw significant improvement. And those improvements were sustained at 14 months, which is really exciting. But most of that improvement, as I said, was limited to that initial 5-day training period. This is particularly notable in the context of other studies. While it's really common for GBV trainings to be successful in improving provider knowledge and confidence, attitudes has historically been much more difficult to shift. One study in particular showed that only 1 in 11 similar studies conducted in high-income settings were successful in improving victim-blaming attitudes. And shifting attitudes is really important given the self-identified needs and desires of Timorese women who are seeking care for GBV. A recent qualitative study of Timorese women showed that they want empathetic providers who share relevant resources while respecting their autonomy. So with that in mind, it's really important that the trainings do not just focus on improving provider knowledge and confidence, but focus on how that care is provided by shifting empathy and attitudes. So it's really exciting that we were able to see attitudes and empathy improvements in the training, despite most of it being linked to that first 5-day period. Second, the value of the learning labs are yet to be fully understood and require further research. It's quite possible, particularly in the context of other literature on similar trainings, that learning labs are maintaining providers' knowledge, confidence, attitudes, system support, and empathy, but we can't say that given the study design. The estimates did trend positively, however, and though they weren't significant, several were approaching significance, and this could be a result of our underpowered study. Given the large investment, both financially and human resources, in the learning labs, it's really important to understand if the 5-day training is enough to improve and sustain scores over time without those learning labs. Without the learning labs, this training would be much more easily to scale across the health system in Timor-Leste. And so ideally, we'll learn more about this in the future. It's important to acknowledge several limitations in this work. The study's lack of a comparison group is the primary limitation of the study. Second, we can't assume that external factors didn't influence provider scores over time. The analysis was constrained by a small sample size, underpowering the analysis and limiting our ability to detect significant effects. This was further complicated by difficulty matching participants across the 3 time points, primarily due to issues with their participant IDs. But despite this limitation, the study is the first of its kind in the Timorese context, and it offers really important lessons learned for the program. In conclusion, we observed improvements across all 5 domains for the 5-day training and possible improvements across the learning lab period for knowledge, empathy, and confidence, which shows promise for a setting that has profoundly high rates of GBV. USAID excitingly just awarded $3.5 million more to expand the Harmonia activity to 2 more municipalities over the next 4 years, which provides a really exciting opportunity to alter the study design to further our understanding of the program, specifically those learning labs. Thank you for listening. I'm happy to take any questions.
Great work. Great presentation, Susan. Really important findings that you presented. I'll just pause for a second and see if there are any questions. There's a lot of kudos in the chat. Okay, then I have a question to throw out there to warm things up after lunch. Were there any challenges noted in implementing the trainings? You know, I'm really impressed with your results. It is unusual to see such change, 5 days after the training, within 5 days of the training. But were there challenges that came up through your surveys?
In the survey, I know in implementation, the 14 months of learning labs were condensed to 8 learning labs, but they still covered all the content. And I believe that was due to issues getting to the facilities every month. The HMNASA team would have to confirm that for me, but there were implementation issues, I know. In the surveys, as I mentioned, the participant IDs were really challenging. And I know on the ground, participant IDs can be hard to keep track of. And so hopefully in the future, there can be a better system for assigning participant IDs and allowing for tracking individuals over time.
Okay, so there were some recommendations for the future work that's going to happen. So thank you. That's nice. Oh, Tara, you have your hand raised.
Yeah. First, Susan, thanks so much for the presentation. It was well articulated, and it was really exciting to see kind of the product of all your work. I know that you had such a great time working with Harmonia throughout the year, so it was really exciting to kind of see the culmination of all your work. I guess I just had a question, or wondering if you could expand on how you guys were kind of conceptualizing empathy and how you were kind of measuring that in your survey. But again, thanks so much for the presentation. It was a joy to listen to.
Thanks, Tara. Yeah, of course. So we use the Toronto Empathy Questionnaire, which is a validated tool It has not been validated in the Timorese context. It's been validated in a lot of other settings, both high income and low and middle income settings. And so that it asks questions kind of about like, do you feel, bad for someone who's experiencing harm or a loss? And then there's a Likert scale, a 4 to 5 point Likert scale on like, yes, I strongly do, down to no, I don't feel bad for them at all. There were kind of several questions in that way. It didn't specifically ask about GBV, which is a little different in that sense compared to the rest of the survey, but was more gauging provider empathy overall for patients. Does that answer your question?
Yes, thank you.
Yeah, of course.
Susan? Hello.
Oh, Nuno, go ahead, ask your question.
Yeah. Susan, I just want to I want to ask that like what was NASA reaction towards your findings?
What was their reaction to the findings?
Yeah.
Yeah, I think to be honest, I think it's a little disappointing that we didn't see improvement in the 14-month learning lab period. And I think that was felt by HMNASA, but I think that is, not giving them credit for the big improvements they saw in the 5-day training period. And so, I need to interface with them some more once because they haven't seen the regression results. So I'll be sharing them with that once the paper's done, and excited to talk with them more to hear their thoughts. But that's kind of the initial reaction I got from them.
Thank you so much.
Yeah.
Well done.
Thanks, Nunu.
Yeah, I see lots of congrats and great job in the chat. Don't see any questions. I hope I'm not missing anything. If you have a question, you can feel free to raise your hand or unmute. Okay. Oh, Ariana, go ahead.
All right, I'll just wrap things up. Susan, such a nice job. It's so great. And you're in such a unique position where USAID is committed to continuing things. So you have an opportunity to like actually see some of your suggestions be heard by funders at a really like vital time. So yeah, just curious to wrap things up, if you can share a little bit about like how you'll be presenting these findings to USAID and what that next step might look like.
Yeah, thanks, Ariana. So previous to this more advanced analysis, I had provided the HMNASA team kind of an initial basic level M&E of the post-intensive training period that they submitted to USAID for their final report. And so I think relying on the HMNASA team's relationships that are well established with USAID in Timor-Leste, this is a really natural follow-up to those results. And so they're in a planning period right now for the next round of funding, and bringing these results to them, hopefully, most likely in a presentation format rather than a paper, to start discussing how we can change the monitoring and evaluation structure. I'm hoping is successful in making the next round of M&E a little more robust.
Great. Well, nice job, Susan. Congratulations. Thank you. And we will go ahead and move on to our next presenter. I didn't see any questions in the chat, but if they come up, would you answer them in the chat? Okay, great. Thank you.
Yeah, of course.
Okay, so our next presenter is Ambar Ahmed, and her chair of their thesis is Amrita Bhatt, and committee member was myself. So Ambar, if you're ready, you have the floor.
Thank you, Diva. Let me just share my screen. Are you able to see the presentation?
Yeah, looks good.
All right. Okay. Okay. Good afternoon, everyone. Thank you for being here, and welcome to the presentation of my thesis titled "The Perceptions and Understanding Among Midwives on Perinatal Mental Health: A Qualitative Exploration in Cox's Bazar, Bangladesh." I'm Ambar Ahmed, and my thesis committee, as Deepa mentioned, consists of Dr. Amrita Bhatt and Deepa Rao. Before we dive into the project, I would like to take a moment to discuss my positionality with respect to this work. I am Bangladeshi. I was born in the US and I grew up in Bangladesh, and I'm a native Bengali speaker. I would like to take a moment here to acknowledge that I did receive my education in Western universities, which is definitely a privilege that I had. And I have also worked in maternal and child health research in Bangladesh for a number of years and worked on projects that closely collaborated with the Ministry of Nursing and Midwifery. So although I do not have any personal experience being in the perinatal period, I am familiar in conducting research on maternal health. As for my role in this project, I facilitated the focus group discussions, transcribed and translated the data, as well as conducted the primary data analysis. So firstly, as we get into the background, I would like to define what I mean by perinatal. I'm speaking about the period during pregnancy and up to 1 year postpartum. So perinatal mental health conditions impact an estimated of 20% of people globally, people who give birth globally, and common conditions include anxiety, depression, and other somatic disorders. In Bangladesh, prevalence rates are approximately 26% for postpartum depression, and 18 to 35% for antenatal depression. However, there's not a lot of literature on the topic, as mental health is highly stigmatized in Bangladesh and has very limited funding allocated towards it, with no specific allocation for perinatal mental health. And this project in particular was a collaborative effort between an NGO, the Hope Foundation for Women and Children of Bangladesh, and Mental Health Matters Washington, to potentially begin building the foundation for improving perinatal mental health in Bangladesh. This study was conducted in Cox's Bazar, a district of Bangladesh. It is in the coastal area and is also one of the poorest districts in the country. And it shares a border with Myanmar. And in 2017, a genocide enacted by the Burmese military on the Rohingya Muslims in Rakhine State forced thousands across the border into Cox's Bazar. And currently there are approximately 1 million forcibly displaced individuals living in camps in this region. The Hope Foundation has been operating in Cox's Bazar since the early 2000s, and they have a hospital, multiple birth centers, and a midwifery training center in the region. And after the influx of the refugees, they established a field hospital to provide maternal care within the camps. And for this study, we spoke to midwives working both in the local hospital and the field hospital. The study was an exploratory study and part of a needs assessment to lay the groundwork for perinatal mental health intervention. So the research objectives were to explore the perceptions and knowledge of midwives on perinatal mental health and to identify factors that act as facilitators and barriers to mental health promotion in Cox's Bazar. To quickly go over the methods used, we recruited our sample from the midwives employed at the Hope Foundation, and we chose those who had been working for longer than 6 months within the facilities in order to ensure familiarity with the organization. For the focus groups, we had samples from 2 different groups of midwives. 6 were from those who worked at health facilities in the Cox's Bazar region, and 8 were from those who were working within the refugee camps specifically. The focus groups were conducted at the workplaces of the midwives, and the data was collected in March and February of last year. For the analysis, the transcripts were created and translated from Bangla to English, and the coding strategies employed were a hybrid of inductive and deductive coding by 2 primary coders, and the coded analysis transcripts were then analyzed to develop the themes. As we get into the results, firstly, I'd like to show the breakdown of the demographics of the participating midwives. We spoke to a total of 14. All of them were between the ages of 20 and 30. Around 85% were Muslim, while 2 were Christian. And of note is that the majority of midwives came from regions outside of Cox's Bazar. For the data analysis, we use this conceptual framework to guide the analysis. This conceptual framework of barriers and facilitators to perinatal mental health care, called the matrix models. The matrix frameworks highlight the complex interplay of individual and system level factors across different stages of the care pathway that influence women accessing PMH care and the effective implementation of PMH services. For the purposes of this study, I was looking at specifically societal, interpersonal, health professional, and individual level factors that have an impact on the care pathway, specifically on the deciding to consult, assessment, referral, and access to treatment portions. For the themes, I decided to split the results into 2 distinct categories, the first of which looks into the roles of midwives as primary healthcare providers within the realm of mental health. indicated by this quote at the top, "This is what mental health means to me." And this section explores midwives' understandings, attitudes, and the challenges they encounter when trying to address mental health issues among their patients. A total of 4 themes were identified. The first being that the midwives have a positive attitude towards mental health and they recognize its importance. Secondly, the midwives were able to identify the multifactorial aspects of maternal mental health, speaking on the environment, the family support, and other factors that influence mental health. Continuing on, midwives also spoke about how they already provide a psychological support role in the perinatal period, particularly at delivery, mentioning that when a mother comes to us, we speak to her in a way so they don't feel any mental tension. It's good for their mental health. However, there is a disconnect between the midwives' perceived importance of mental health and them potentially minimizing the impact of mental health conditions, possibly due to a lack of knowledge and training. When asked to define certain conditions of perinatal mental health, such as depression and anxiety, midwives were lacking in confidence, saying depression means worry or anxiety means tension. And secondly, as I mentioned before, mental health is poorly understood in Bangladesh, and this poses a great barrier to providing mental health care. So for the second category of themes that have been grouped under this quote that says they have doctors on even this in Bangladesh, within there we have the strongest feeling was that the certain societal structures common to this region of the world act as a barrier. Factors such as the early age of marriage, gender preference for boys, these were identified as factors as reasons for poor mental health in the perinatal period. In the same vein, familial dynamics were also identified as a potential cause of poor mental health, poor relationships with in-laws, the outsized influence of the mother-in-law and household decision-making, and the behavior of the family at delivery, particularly if the baby is a boy, were identified as factors. And this quote in particular really does demonstrate how mental health is viewed in Bangladesh, with the midwife stating that she had a patient who was suffering from depression, and when offered counseling services, the mother-in-law was very dismissive. But however, when speaking to the mother directly, she had a much more receptive attitude. Lastly, societal stigma remains one of the largest challenges of mental health care provision in Bangladesh. There is a high level of taboo associated with seeking mental health care, and the assumption being that only so-called crazy people go to see a counselor, as illustrated by this quote on the left, which says if someone goes to a counselor, they think that they have gone crazy, where the midwife was describing the attitudes of the society at large. And lastly, for the final theme, we were looking specifically at the treatment received by the Rohingya women. And what we found there that there was a lack of cultural congruence between the Rohingya patients and midwives. A caveat here, we did not speak directly to the Rohingya women, and that is a limitation of our study. However, the midwives mentioned that a lot of the Rohingya say that the sister is not very covered, meaning the midwife. I will not take care from her. I will take care from those who are more covered, despite the fact that Bangladesh is 90% Muslim and the midwives were overwhelmingly Muslim hijabi women. The ones we spoke to still felt there was an instance of cultural and religious incongruence. And there's also a language barrier here, as well as the midwives did not receive any specific training on working with vulnerable groups. It's to quickly summarize the findings, the midwives demonstrate positive attitudes towards perinatal mental health, but they lack the clinical knowledge and cultural congruency. Midwives also currently play a role in non-specialist PMH support, and this underscores potential for task sharing initiatives to improve access to care in the future. And lastly, there's definitely a need for tailored training, language alignment, and cultural sensitivity to enhance PMH interventions in Bangladesh. Finally, I would like to take this moment to thank my study participants, my PI and second coder, Annika Sahoda, my thesis committee, for their guidance throughout this whole project, the Hope Foundation, Mental Health Matters Washington, and the UW Population Health Initiative. Thank you. I think I may have gone a bit over.
Oh, you're totally fine. Thank you so much, Umbar. Great presentation. It was so nice to hear the summary of your work and to see it get this far. You know, it grew and concluded in such a nice way. I have a quick question And I don't see anything in the chat yet, but if you have any questions, feel free to put in the chat or raise your hand. My question is basically, you know, it's actually unusual to see the healthcare workers themselves not holding stigmatizing attitudes towards depression. I mean, usually the healthcare workers kind of their attitudes match the public. And it seemed like there was kind of less of it amongst the people that you interviewed. What do you think contributed to that? Is it the way that the terms are used, or, you know, is it a true finding, or, you know?
It is definitely interesting because I think there's one other person who studied perinatal mental health in Bangladesh with midwives specifically, and they also found instances of the stigmatizing attitudes. But with this group, I think I do think that these were the true findings, because Hope Foundation, they do have mental health care services available, and there's like if not a very extensive level of training, but there's some level of like familiarization, which may have helped reduce the stigmatizing attitudes there. That is my potential guess.
Yeah, makes sense. Thank you. Others have questions? We have 3 minutes, so. Actually, so Marianne just put in a comment about worth more investigation. So I'm going to ask you about future directions for this work. Do you know where this is going, or what are the next steps with the study? Oh, and then Maren has a question. So maybe you can quickly answer both because we have time.
Yeah, so for future steps, we are hoping to get some funding to potentially build out a training curriculum based on the initial needs assessment for the midwives working at Hope. And prior to that, I think there would definitely be more directed interviews and focus groups to figure out exactly which areas to target, though I think this provides a good framework from which to build on.
Okay, and we'll take one last question from Maren. Thanks, Amber.
Hi, Amber. Great job. Oh, sorry.
Oh, sorry, we are at time for.
Oh. Well, let Maren ask the question. We'll make up time later. Don't worry.
Sorry. I was just curious about kind of you mentioned like existing stigma, and so just wondering, you know, how people think about perinatal mental health. And I know you cover this somewhat in your discussion, but you know, what kinds of things are needing to be overcome from, I guess, from what you saw, like, I guess, what sort of stigma might exist? Like, what do people think currently about perinatal mental health?
I think the general consensus was that most people are not aware of mental health being something that needs to be addressed at all. So we're starting from a very basic, like, sort of awareness building within the communities, especially in the more rural areas. And this was reflected with what the midwife said as well, that those families that have a higher education attainment levels and then also socioeconomic status, those act as protective factors. So yeah, we're starting from pretty low levels of just not acknowledging mental health as an issue, and also thinking that the only considerations there would be if someone is exhibiting severe symptoms.
Okay. Thank you so much, Amber. Great presentation. Congrats on being finished. We're so happy for you. So,
thank you.
Okay, and we'll move on to the next presenter, who is Claire Rader, who will be presenting our certificate capstone. You have the floor.
Thank you. Hi, I'm going to share my screen. Hi. Yeah, so my name is Claire Rader, and I'll be presenting on reducing sugared fruit drinks in Alaska Native children in Bethel, Alaska. I was originally slated to present on something different, so thank you for letting me make this last minute pivot. I worked on this project with the University of Washington School of Dentistry. So my background in positionality, I'm currently a Master's of Public Health and Master's of Social Work candidate, finishing this spring. And I'm also getting my certificate in global health, which is why I am presenting today on work that I did through my certificate of global health. So I have experience working in cultural humility, community integration, and anti-racist work through the Peace Corps, AmeriCorps, my school of social work training, my school of public health training, and my teaching assistantship at the University of Washington School of Public Health. And I lived in Juneau, Alaska from 2020 to 2021 during my time as an AmeriCorps member. At that time, I was working on public health for maternal and child health among Alaska Native communities. But I was born and raised in the Midwest, so I'm not Alaska Native. I am not from Alaska. I'm a researcher from the University of Washington, so I don't share identities with the communities and individuals that I was working with. And that definitely influenced the way that I was interacting with those communities. So the problem that our study was working to address was sugar consumption in the YK Delta region. So UPIC children experience tooth decay rates at 16 times the national average and are consuming 50 teaspoons of sugar per day, which is 16 times the American Heart Association's recommended maximum. The key risk factor for this problem is sugary drinks, and in these communities, Tang and Kool-Aid are the most commonly consumed drinks and are usually bought from local stores in those communities. So in this picture, you can see that a can of Progresso soup was about $7. And then that was at my first visit, and at my second visit, it had raised to about $8. So food is very expensive in these communities, and Tang and Kool-Aid are cheap options that a lot of families can afford to, give juice to their children. So this is where the study took place. So outside of Bethel, Alaska, in rural and isolated communities. So in this photo on the right, you can see a picture I took from one of the prop planes that we would take to travel between villages. The terrain is tundra, and it's impassable. So you have to take a plane. Some people can take ATVs, but these communities, it gives a little bit of a glance at how isolated and how rural these communities are. On the left, you can kind of see what one of these villages looks like from an aerial view. So the study that we were working on was PI'd by Dr. Donald Chi at the university, or at the School of Dentistry. And the research was precedented by 5 years of research in the region to develop the most culturally appropriate intervention. And Dr. Donald Chi also has spent years before that time working in these regions and building relationships. So the study is a 2-arm quasi-experimental behavioral trial in 3 small and isolated Alaska Native communities outside of Bethel. And again, you can kind of see a picture on the left of the terrain, and you can get an idea of how difficult it would be to get food in and out of these communities. Bethel is already a small town in Alaska, and it's difficult to get there. And then to get from Bethel to these other communities is really difficult. So getting food and drink that does reduce sugar consumption can be really difficult to get into these communities. So the hypothesis for this study was that community health worker-led health education and self-efficacy training for caregivers would decrease child added sugar intake. And the intervention was to provide education as well as sugar-free water enhancers that would be made available at the local stores. So here are a couple of pictures of what those stores look like. You can kind of see not everything is completely stocked. Stockouts are really common, and it can be difficult to get food again. So the aims of this project was to complete the pre-intervention activities and finalize intervention, implement the intervention, and assess the outcomes, and identify intervention improvement opportunities and disseminate findings. So in this photo, this is where we would conduct all of the surveys and interviews that we would do. This is a health clinic in one of the local communities. Each of the communities that we were in had a local health clinic, and each of these communities was fewer than 1,000 people, more like 300 to 600 people that lived in these villages. So the clinic was kind of a pillar in the community. Community health workers staffed the clinics as well as nurses. During this project study, we would sleep in these clinics, as is common for different health professionals to come in and provide specialized care. Thank you. And so the methods for collecting the data was we would do dietary recall, hair biomarker. So kind of the order of events was to do that dietary recall, collect hair biomarkers, get education from the community health worker, and then hand out the free sugar-free water enhancers. So the study was conducted, visits were conducted at baseline, 3 months, 6 months, 9 months, and 12 months. And I did the dietary recall at 3 months. And the dietary recall is asking participants everything that their child consumed in the past 24 hours. This includes water, it includes drinks, and it's very detailed. There's a lot of questions to capture it really effectively. If participants would come in with 5 children, this would take a really, really long time. After the 3-month visit, this ended up getting cut, and the hair biomarker was the only tool that was used to assess nutrition, which was still very effective and just lessened the burden on participants. You can also see in this photo the kind of serving size units that we would show to participants during the dietary recall. We would have to mark like how much of the food the participant ate, which was again really time consuming. So really important part of this, and the big role that I played, was cultural humility in data collection. I was really happy that this project was developed with community-based participatory research in mind. As I mentioned, relationships have been being built in these communities between the University of Washington School of Dentistry and Dr. Donald Chi, the PI, for 5+ years before this. In recruiting for the study and getting people to come to the study, it was really easy because, again, these communities were really small, and people felt there was a lot of trust with the research team to come in and go through the study, and the incentive of getting the free sugar water, or the sugar-free water enhancers, was another incentive. But it did come up often, that I was a researcher from Seattle, and that would create distance between me and the participants. And I really appreciated that this study was conducted over a year-long period, and there was an emphasis on having the same volunteers come to do the same surveys to continue to build trust with the community. So I was able to build as much trust and relationship build as much as I could with the limited time that I had, but there was already a really good baseline of that happening. And the research project was developed with the community, for the community, and with the community's needs in mind, which was really important. So the final results are actually still in progress. So that has not been published yet, but we're hoping to see that this intervention was really helpful. Tooth decay is a really big problem for children. It can directly impact their mental health and has really high correlation with school dropout rates, as well as other physical health problems. So it's really important to reduce the sugar consumption that happens in these communities, and just being part of just getting to visit these communities, you can see that it really is a big problem. And the kind of moving away from traditional Alaska Native diets and towards more Western diets has created a big problem there as well. So yeah, thank you. These are some photos. Overall is a really beautiful, really beautiful place to be. It is super isolated, so I felt very grateful to be able to visit these communities and meet the people who are there. Yeah, so thank you.
Thank you. What a nice presentation and study. It's really nice to hear about a different population that we don't get to normally hear about. So thank you. I don't see any questions in the chat. I have one for you to warm things up, just in case people are, having carbohydrate coma after lunch. So my question is, so you mentioned the pricing of food, which was staggering. And I know this wasn't part of your study, but I start to think about the system that we're within, and why do you think food is priced that way? And is there any way that, you know, this community can lobby to get that changed, or to, you know, to intervene at that level, at pricing and that sort of thing?
So I think it's difficult because to get food to these communities, the food comes from, to get kind of food that's like staple food that is found in grocery stores, it comes from Seattle, which then has to fly to Anchorage, which then has to fly to Bethel, which then has to fly to these communities. And I think I mentioned, but there's no way to pass through these communities without flying, because of the tundra, because of the terrain. There's just no way to get to community without that. So I think that has a huge impact on the way that food is priced. And while Westernization has caused a lot of problems for that, these communities do still heavily rely on traditional Alaska Native diets. And I know that there's a lot of work being done to kind of continue to preserve that, both through, you know, environmental work, to preserve the food and environment, as well as cultural work that's working to make sure that kind of taking that food out of the westernized food out of the equation, to just kind of further sustain these traditional Alaska Native diets, which are much more sustainable and of course affordable for these communities. But it's really hard.
Yeah. Yeah, thank you. There is a question in the chat. Awa Kone asks, nice work, Claire. I may have missed this. How did you get interested in this study?
Yeah, so one of my research areas is rural healthcare. I'm really interested in the different challenges that rural communities face specifically, especially really isolated in rural communities. And these are really good examples of that. And again, I lived in Alaska and was just really taken by the culture there, and the beauty, and I'm really passionate about working to kind of preserve that culture. And the challenges that rural communities face in Alaska are really unique. It's crazy. The challenges that they face are not faced by many communities in the United States. And this is part of the United States. And it's really fascinating to think about, you know, how limited access to healthcare is. And if someone wants to get a dental appointment or wants to get an eye appointment, they might have to travel all the way to Seattle or Anchorage to get that. So I just think the resiliency that comes through from the communities that are, you know, that live in these isolated regions, I think is really it's kind of just incredible to witness. And I'm really passionate about continuing to work in those types of settings.
Okay, great. Thank you for the answer. Any other questions? Okay, well, the one thing is we aren't necessarily able to move on. Our next presentation is actually scheduled for 1:05. We had a cancellation that gave us a few extra minutes here. So why don't we use the next 10 minutes for a break? And if everyone could come back around 1 o'clock, if we're here early, we can get started at 1 o'clock. But I think Rachel Reinhardt is next, and Rachel's committee is not yet here. So we'll wait till 1 o'clock at least, if not 1:05 to begin. Okay, well, it's my pleasure to introduce Rachel Reinhardt, who will be presenting her thesis here today, and her chair is Lydia Chwastiak, and committee member is Scott Graupensberger. So you have the floor. I hope you're able to share your slides and everything, but we'll coach you through if you have any trouble.
Okay. Let's see. Can you all see that okay?
Yeah, it looks great.
Okay. Well, thank you all for being here. Like Deepa said, I'm Rachel Reinhart, and I'm really excited to share with you my thesis on healthcare utilization of U.S. adults with suicidality. I worked with Dr. Lydia Chiswastiak and Dr. Scott Graupensberger on this project. For background, suicide has been increasing over the last 20 years. Now about 1 in 50 people pass away from suicide in the United States. There's been a lot of research going on around risk factors that relate to suicide that might lead someone to experience suicidality in their health. And those things include things like, marital status, education, like health insurance, different factors, and what kinds of treatments can be done for them. But we haven't had a lot of research about what might be preventing people from actually seeking treatment. And that's the format of my presentation and of my thesis. I wanted to learn more about what might be preventing people from seeking care that's so important, because about 80% of people who experience suicidality have a mental illness concurrently. So what could we do to help engage them in mental health care? So the aims of my study were to look at 3 different groups: people who experienced suicidal ideation in the past year, people who experienced a suicide attempt in the past year, and people who had neither of those conditions. And I wanted to compare those groups to each other, not just for risk factors that might contribute to experiencing suicidality, but also what are some risk factors that affect care, and what does their care look like in the past year as well. So I utilized data from the Mental Health and Substance Use Disorders Prevalence Study, or MDPS, which is a large study over 5,000 people that was just released last year. And it was one of the first of its kind, actually the first of its kind to my knowledge, to collect clinical data on a cohort of this size. It was cross-sectional in nature, and I utilized the household sample of it, which was about 4,000 individuals in my research. I used RStudio for analysis to do multiple logistic regressions, and each regression was weighted, as well as the demographic was weighted, as you'll see here in a second. So for results, demographics, you'll see that some of them have a little star next to it. Those were just demographics where the confidence intervals for either the suicidal ideation group, SI, or suicide attempt group, SA, had a confidence interval outside of the confidence interval of the no SI, SA group. So looking at specific groups, younger people tended to have SI or SA, and then people with income less than $20,000 a year also tended to have SI, SA when I was looking at demographics. This is the race category that I looked at. The only thing I really wanted to point out here was that you'll see American Indian, Alaska Native, and Native Hawaiian Islander / other Pacific Islander groups are quite small, and that affected the outcomes of some of our regressions. Lastly, we have education. A graduate and professional degree had more of a difference compared to some of the other education groups when it came to suicidality, in that people with a graduate or professional degree tended to have a lower, less likelihood of being in the suicidality groups. And then the last group that I looked at was the inpatient, outpatient, and prescription medication groups. These all, you can see, have quite a large difference. And this is showing that people with SI and SA tended to have had also a lot more mental health care in the past year, which makes a lot of sense, as this was all collected at the same time point. It's not clear whether they received those services before they experienced suicidality or after. And likewise, you'll see that in my first regressions. So these are all regressions that I did that compare the 3 different groups that we're focusing on and how it affected inpatient, outpatient, and medication groups, all related to mental health specifically in the past year. And I controlled all of these logistic regressions for age, race, sex, ethnicity, and education. And you'll see that when we compare the SI groups and the SA groups to no SI, SA, they consistently had greater amounts of inpatient, outpatient, and medication use care. And amongst them, people with a suicide attempt in the past year had the most mental health care in the past year as well. You know, seeing 20 to 72 odds ratios. And then when I compared those two groups, the SIA group and the SII group, the SA group typically had more mental health care than the suicidal ideation group when compared directly as well. My next regression was a large model that I created that looked at various risk factors amongst people who had experienced suicide ideation or suicide attempt in the past year. And what I wanted to look at here was the main question I had in the study was, what are the risk factors that might affect people's ability to seek care when they're suicidal? So this is just the first of two slides of this, fair warning. The first slide is mostly focusing on the demographic risk factors that I chose. And you'll see that first looking at the inpatient side of this, there is bolded significant figures such as race. In fact, Asian individuals had an odds ratio of 0.08 times compared to their white counterparts. You'll also see that Alaska Native and Native Hawaiian individuals, especially, there was a large p-value for this, but the issue being there is that we had a very small sample size for that group. So it's likely that we can't actually use that data point because it's too small of a cell size to actually compare there. And there's a couple of other ones that I'll point out there as well. However, when we look at public health insurance is the other one to point out, is that it had a referent of 0 because of the 77 people who both had no insurance and had experienced suicidality, none of them had had any inpatient care, unfortunately. So, I mean, it speaks to, of comparing several hundred people to each other, of the 77 who didn't have insurance, none of them had care. It does say something, but unfortunately, we can't really statistically compare that because there is no referent group. Looking at outpatient care, similarly, there's a difference for education. You see that people with a college or associate's degree are more likely to have received outpatient care compared to those who had less than high school education. Females were more likely to have outpatient care compared to males, and individuals of minority groups such as Black, African American, and Asian individuals were less likely to have had outpatient care. And then lastly, on the insurance side of this, we actually did have a better test here of public insurance having been more likely to have received care than those without insurance. The last group of risk factors that I looked at that were also within this model was substance use disorder and mental illness in the past year, and how that might have affected people's ability to seek care, or whether or not they did seek care at all. And so you'll see on average, individuals who had a mental illness in the past year were more likely to have received outpatient care. People with substance use disorder were more likely to have received inpatient care compared to those who had not. And, thinking about that, it's not clear to me why those were different, why there's a stratification between inpatient and outpatient. I can only think that perhaps individuals with mental illness were more likely to have needed outpatient care because of their mental illness, whereas those with stimulant use disorder might have been severe enough to warrant inpatient care. There are some limitations to the study, mostly of which are its cross-sectional study design, because it leaves a lot of questions regarding why did individuals in the groups of interest end up seeking mental health care in the first place? Was it before they experienced suicidal ideation or attempt, or was it after as a result of having those symptoms? Additionally, the maximum age was 65 years old, so we're missing the older individuals when we compare age, and we had limited numbers in some groups, like I mentioned, which affected the ability to actually compare them in the regressions. A large number of variables were measured in the model as well, which is important because we could have a multiple comparison problem where it's too many values that could lead to increased likelihood for one of them to be significant. I think this important things to talk about here is inequity, stigma, and clinical implications for clinical interventions. In terms of inequity, we see a lot of the groups that had less care are groups that are often marginalized, but some, like men, could be stigmatized as well. So it's worth considering that when giving care. And here's my conclusion. It's just talking about everything that I just mentioned with our results and a little bit of our discussion. And I think I'm out of time, so I'm going to stop there. But I also just wanted to quickly thank you all for coming to my presentation, and especially to thank Scott and Lydia for being wonderful mentors. Thank you.
Great presentation, Rachel. Thank you so much. I do have a question that I'll ask if I see no other questions or any other raised hands. Okay, I'll ask my question then. It's really interesting because I was writing my question down before you got to the slide where you talked about, you know, the limitations of having the variables in the data set to analyze. So I guess I'll adjust my question and ask if you had a wish list of another variable or two you would have liked to look at to investigate, you know, risk factors around poor healthcare utilization. What would you have picked? What do you suspect, I guess, is contributing to you know, poor utilization?
That's a great question. The MDPS data was so thorough that I really was very fortunate to have many different things to choose from. I think something that could be interesting to look at would be things like transportation access, you know, not just looking at income and education and those kinds of things, but more some practical things too, like do people have access to transportation to get to healthcare as well?
Okay. Thank you. So audience, any questions? Steve, I see you have unmuted. Does that mean you have a question?
Yeah, I had my hand up, but I think I put it down. Really nice presentation, Rachel. Can you describe a little bit the sample, the MDPS sample? I mean, and how they got the sample, you know, where they came from? Because it's unclear to me, are these people who are, you know, coming from health background, from household sampling, and how do they represent the sort of the general population?
Sure. So the MDPS data set as a whole was collected across the country and through several different universities, and they collected a household sample, I believe a prison sample, and then an inpatient sample. And I just used data from the household sample and then weighted it to be more representative of the rest of the country as well.
Thanks.
Yeah.
Just pause to see if there are any questions. I've got another one. Okay, good. Susan saved me from asking my question number 2. So go ahead and ask Susan your question.
Yeah, great job, Rachel. I'm curious, this is a little bit outside of the bounds of just your project, but as a clinician who's working in this space, I'm curious how you integrate this into your practice or how you think you might, if at all.
That's a great question too. I think my hope was really to do work that is big, that I can integrate into my practice, because that's the whole point to me of doing research is further understanding so that we can further our patient care too. And I think for me, you know, seeing things like men were less likely to have sought care, racial minorities, I think that's leaving opportunity for us as providers to then do something about that, to reach out to those groups, to try to, you know, reduce stigma and increase awareness. And then we can target those groups more effectively as well. And then also recognizing where the inequities are strongest. So then we know where to put what funding we have most strongly towards those groups as well.
Awesome, thank you.
Yeah, thank you.
Great. Any other questions? Okay, would you mind telling us a little bit about the next step for this work? And then probably that's the last question we'd have time for.
Okay. So I'm planning to finish up the writing for this thesis and hopefully doing it justice in a way that it can be published in a journal. I have yet to decide which journal to publish it in yet. So if anybody has any recommendations, please let me know. But that's the plan.
Great. Well, good to see it come together like this. Thank you. Congratulations. Great presentation.
Thank you.
Yeah. So we'll move on to the next presenter. I think we're right on time, so that's great. Next presenter is Tara McCoy, and the chair of your work was James Pfeiffer and committee member Judith Wasserheit. So I think everyone's here, so you have the floor, unless you'd like to pause or anything like that. But oh yeah, everybody's here. Okay, go ahead, Tara, you have the floor.
All right, let's go big real quick. Okay, and you can see my screen?
Yeah, sorry, I muted.
Okay.
It's a little cut off at the bottom, but I don't know if that's going to make a big difference or not. But
It shouldn't. I think it should be good.
okay.
All right. So hi everyone, my name is Tara McCoy. I'm going to be presenting my thesis, exploring innovative models for national pandemic disease preparedness and response, a qualitative analysis of multilateral leaders' perceptions of opportunities and challenges, with my committee, Dr. James Pfeiffer and Dr. Judith Wasserheit. So I'll actually start with my positionality statement up front. I am a white female identifying graduate student born and raised in the United States. My native language is English. I do have limited experience working within multilateral organizations, which is the community largely that our participants are drawn from. So just want to put that up front. So now getting into the background here. The COVID-19 impacted every sector of society, from agriculture and education to business, tourism, travel. The pandemic revealed severe gaps in countries' preparedness and response capacity to pandemics, but it also presents an opportunity to think through and reimagine a more equitable and collaborative global health security future. Emerging infectious diseases of pandemic potential have increased in frequency over the past several years, making it more important than ever to understand how to integrate and operationalize multi-sectoral collaboration. So here on the right is a conceptual framework we were kind of using to think through this. So those four bubbles in the middle are prevention, preparedness, response, and recovery, and they're connected to these kind of outer sectors, and these sectors are also connected to each other. And so it's really interesting to understand the roles and responsibilities for each sector in each of these phases, but also how these sectors are interacting with each other. We also recognize that these sectors are operating within a larger economic, social, political, and organizational context. So there have been several international efforts underway following the pandemic. There's the Pandemic Accord, revisions to the International Health Regulation. There's the One Health Joint Plan of Action, and a pandemic fund, all of which kind of reference the need for multi-sectoral collaboration. However, we need to better understand multi-sectoral strategies for national and subnational levels, as this is kind of where the rubber hits the road, as Judy would say. So getting into the research goal, it's to identify important issues to consider from the global perspective for the development of sustainable multi-sectoral strategies and mechanisms at the national level. And so there are three key objectives here. The first is to identify lessons learned from the COVID-19 pandemic and prior pandemics. Second, to elucidate the roles of health and non-health sectors, including academia. And third, to understand the opportunities and challenges for multi-sectoral strategies and mechanisms. So getting into methods, this study aimed to interview high-level leaders for multilateral organizations about their perspectives and experiences. We used politically important case selection and snowball sampling. As these are high-level leaders at international organizations, they're often difficult to reach without any kind of connection, making snowball sampling a useful sampling strategy here. We used a combined deductive and inductive approach to the analysis process and conducted thematic analysis of the data to get our kind of key takeaways here. So for the key informant interviews, we conducted 16 key informant interviews representing 5 sectors: animal health, agriculture, education, environment, and human health. And these interviewees represented 11 different multilateral organizations, ranging from Food and Agriculture Organization to World Meteorological Organization. So our results here are organized into 3 thematic categories that correspond to our 3 objectives. So lessons learned for pandemic prevention, preparedness, and response, multi-sectoral roles and relationships, and then multi-sectoral mechanism. So first, getting into some of the lessons learned, there were 5 themes that kind of emerged under lessons learned from participants. The first being this idea of prior experience. So the idea that countries that have prior or ongoing
experience with dealing with outbreaks or epidemics help shift preparedness efforts, that prior experience helps to build up what participants kept referring to as muscle memory. So they were able to kind of adapt their responses more effectively to the pandemic. The second here is pre-existing capacity in relationships. So this kind of refers to capacity and relationships that are developed during what participants would call peacetime. So these kind of preparedness and prevention efforts. So a response was limited by a country's pre-existing capacity, the capacity to scale up and adapt to changes in the pandemic. And then pre-existing relationships here refers to relationships formed whether informally or formally between sectors prior to the onset of the pandemic. So formally could be, there may have been like a One Health national platform that helped to bring these actors together, and informally may have been just kind of relationships between colleagues that happen to work in different sectors. But these pre-existing relationships were thought to facilitate improved collaboration. In terms of leadership, this refers to the importance of national leaders to the pandemic response, but also to preparedness efforts. So in the response, if you had a leader that was listening to the science and that was kind of providing an operating environment for the health sector, that was thought to facilitate a better response. And then in terms of preparedness efforts, having a leader that recognizes the importance of prevention and preparedness is very important for kind of sustaining political will and interest and funding those kind of efforts. In terms of communication and trust, it's the ability to communicate shifting information largely from the health sector. So participants noted kind of the challenge with kind of changing recommendations and guidance based on the science, and how to communicate to the public that a change in guidance isn't necessarily a failure, but it's actually a success, that we're learning more about it. And then this fifth point about the cycle of panic and neglect is not so much a lessons learned, but I do think it's something very interesting that came out of these discussions, that you know, there was a lot of attention during the response, and then it seems like after folks are no longer as interested in preparedness and prevention. And so several participants noted their concerns that governments were moving on too quickly from the pandemic. In the second bucket, we get into roles that the health sector, non-health sector, and academia should play. For the health sector, that was providing evidence-based guidance to policymakers and communicating guidance and new information. However, they noted that their ability to perform their function was also limited by pre-existing capacity of the health system, as well as the leadership they operated under. So again, getting back to that operating environment. They noted that often they had that folks had high expectations of them, and they couldn't always meet that. For the non-health sector, participants noted that their ability to engage in multi-sectoral collaboration was often limited to their own pre-existing capacity, with participants noting that non-health sectors may be even less funded and capacitated than the health sector. And in terms of academia, participants noted that academia's primary importance lay in its research capabilities. Participants kind of secondarily mentioned training and education, but it wasn't, they didn't think that was the primary importance of academia. And then for academia, there were similar challenges of communication and pre-existing capacity that were noted. Lastly, in terms of multi-sectoral mechanisms, participants actually provided few clear recommendations for creating sustainable mechanisms. There was one participant that suggested creating something akin to a disease situation room that would help with coordination in the event of a health emergency that would be led by some kind of pandemic manager. Another participant suggested building pandemic prevention and preparedness into existing emergency and disaster management protocols and systems. So while there was not necessarily agreement on the structure and mechanism would ideally take, participants noted that mechanisms should be politically empowered, adaptable, and integrated. Politically empowered in the sense that they should have the backing of the national government, whether that's the president, the prime minister, etc., in order to kind of gain legitimacy. Adaptable in that they should be able to respond to different types of health emergencies and be able to pull in appropriate sectors. And integrated in that they shouldn't, that this mechanism, in whatever form it should take, shouldn't be sitting in some kind of institute that's away from the government, but should rather be integrated into government systems.
1:30.
So in conclusion, kind of going back to those three objectives, for lessons learned, addressing capacity and resources alone does not guarantee success. So leadership, trust, and communication are just as important. Poor leadership can squander ample capacity, and excellent leadership can make the most with limited capacity. And it's important here too, though, that it's not just about building that within the health sector, but it's building that across sectors as well. In terms of roles, sectors have incomplete understandings of other sectors' capacities, roles, and responsibilities. While sectoral representatives agreed that health could not do this alone, there was confusion surrounding the roles non-health sector should play, or the roles that they should be expected to play in a pandemic response. And then finally, there's a need to better understand how to operationalize and sustain multi-sectoral collaboration at the national level, whether that entails kind of further research into existing mechanisms at the national level to better understand what works and what doesn't work. For example, there's a multi-hazard emergency preparedness and response plan in Nigeria. So maybe further research should kind of look into how did it come about, what are the processes, and what does sustaining intersectoral collaboration between pandemics or between health emergencies look like? And so finally, I would love to thank Dr. James Pfeiffer, who's my chair, Dr. Ruth Wasserheit, who conducted the interviews and whose project I was a part of, as well as Arancho Tripura and Daniel, who are all helping with the project as well. And then the HRC 7th floor and the 6th floor coffee machine. That's it.
You got to thank the coffee machine.
Oh, absolutely. I mean,
Yeah.
it's a godsend.
Great work, great presentation. Thank you for presenting such interesting, rich findings. Would you mind commenting on next steps for the project and your findings and dissemination, that sort of thing?
Yeah, so this was actually just one side of the project. So there was kind of a concurrent study going on at the national level in Peru that was asking the same questions, but it was of national level representatives as well. And so the next step is to kind of compare the two perspectives of this perspective that's a bit more far removed, this multilateral, global, international perspective of what they think a multi-sectoral mechanism or what that collaboration looks like versus what leaders at the national level in Peru are actually thinking that should look like. So that's kind of the next step, is that comparative piece.
Okay, thank you. The audience, feel free to raise your hand, ask a question, or put a question in the chat. I hope I didn't miss anything that was in there already. Lots of great presentations and kudos for you in the chat. So take a moment to read them. You have a full 3 minutes. Okay, great. Judy, you have a question. Go ahead and unmute and ask.
Thanks, Deepa. Tara, that was wonderful. Really nicely done. You know, this whole piece about the cycles of panic and neglect and sustaining interest, and along with interest funding, I think is really important. Did you feel like you got any insights from the interviews about strategies to do better on that? Because we talked to a number of people who are at pretty high levels in these multilaterals who I know are really angsting about this right now. So what's your sense of that?
Yeah, I mean, I think that's a tough question. But I think some of it, and this was, I think this came from some participants themselves, was just marketing, like public health needs to market itself better, and how to market pandemic preparedness and prevention so that it's not kind of seen as just this drain on cash, but it's something that's like an investment in the future. Some folks are like, maybe we should use more economic language. If we use economic language, then maybe that'll make them understand the impact. But I also think that there's something to getting other sectors involved. I think if other sectors feel that they have a stake or some ownership of parts of prevention and preparedness, and that's built into their budgets and their kind of funding levels too, then maybe there's something there to helping to sustain interest if they feel that they understand their role in that a bit better. But I think that that's also like an avenue for future research as well, is just to better understand how to sustain that, because I think a lot of folks, were perplexed by that, and I don't know that there were a lot of solutions that came out of it. But just kind of this overwhelming fear of forgetting, as people kept saying.
Yeah, we see this every time. I mean, this is, you know, this is not new. We've seen this movie before. We haven't figured it out yet.
Hey, great. Thanks for the rich answer. Any other questions? from the audience? James, go ahead.
Only if there's no other questions. But amazing job, Tara, and amazing job, Will, for keeping us all on our toes with time. I love your little clock circle there. I was watching it throughout, and Tara finished at exactly 10 minutes. It was quite impressive. Just super quickly, Tara, I know that, you know, part of this project that Judy is leading, really interesting project, is working with the Peruvian group who are looking at interviews with Peruvians. And I'm wondering if there's any themes that you're picking up that are common to the Peruvian experience versus a global experience, and anything that is dramatically different. Are you picking up any of that yet, or is it too early to tell?
We haven't necessarily done the complete kind of comparative piece yet, so it may be too early. I haven't really dived into the Peruvian data yet, so I would be hesitant to offer any huge insights there. I will say that there are some similarities in talking about the multi-sectoral mechanism in terms of like general confusion, or not even confusion, but kind of uncertainty of how to implement or institute something like that, especially in a system which is bureaucratized and things are siloed. And so even within human health, there are like silos in different disciplines within that human health. And so I think that that's a common feature. And I think some of those challenges of capacity came out a lot at the national level, but I would be hesitant to offer any formal insights at this point.
Okay, great. Again, right on time. So thank you so much for your presentation. Congratulations. And we'll move on to the next presenter then, who is Peng Tut. And Peng, I think you're here. And I hope that all of your supporters are here as well. Great. Hello. You're presenting your thesis, and the chair is Adrienne Shapiro and committee member Sylvia LaCourse. So thank you, and the floor is yours.
Thank you. Can you see me okay?
We don't see your presentation. I see a Zoom launch meeting screen. I see your web browser. It's okay. There you go. And now I see your notes. So if you put it in presentation mode, it should work. Yep. Yep.
Good afternoon, everyone.
Oh,
So thanks for being here.
1 second. Your chair is in the waiting room. So let's
Sure,
wait for
sorry.
her to join. Coming on now. Want to make sure she's here to hear it. Okay, are we okay, Salam? To start?
We're good to go.
Okay, good. Great. Peng, sorry to interrupt you, but go ahead.
Thank you. So good afternoon, everyone. So thanks for being here today. My name is Peng Tut, and I will be presenting the finding from my thesis project on the tuberculosis preventive therapy initiation completion rates and influence factor among peer HIV in KwaZulu-Natal province in South Africa. I work with Dr. Adrian, who is PI for this primary study and my thesis chair, and Dr. Xavier as my thesis committee. As for my positionality, I'm a queer Asian male from Myanmar and previously worked as a medical doctor and public health professional back in my country. Currently, I'm MPH graduate student from Department of Global Health. My research interests and experience are working in the area of sexual and reproductive health, HIV, STI, and TB programs. For this project, I conducted secondary data analysis using quantitative method. So as for the study background, TB remained a major global health concern, especially for the people living with HIV. And KwaZulu-Natal province has a very high TB-HIV co-infection burden. Although the WHO and South African national guideline recommend the TBT alongside the antiretroviral therapy for the HIV patient to prevent TB, implementation of the TBT is facing challenges in the high burden setting. There are two study aims. The aim one is we determine the TBT initiation rate and explore the associated factor among the eligible pale HIV attending the HIV care in South Africa. we hypothesized that initiation rates vary by the systemic, social, demographic, behavioral, and clinical factors. Aim 2 is we determine the TBD completion rate among the initiator and explore the influencing factor. And we also hypothesize that completion rate also associated with the same factor category. So in terms of methods, we use a nested cohort study design, analyzing the data from the drop TB cohort, which stands for diagnostic routine for the HMP outpatients. The study site were two departmental health clinic, one from the peri-urban, one from the rural and the Unkanyakudi district of the KwaZulu-Natal province. The study population include the HIV positive adult over 18 years old who enrolled between November 2021 and April 2024. And they were screened for TB when they're starting the HIV treatment and restarting the treatment. So data collection involved the baseline questionnaire, capturing the socio-demographic, behavioral, and clinical information. We also obtained the lab result and conduct follow-up with the phone or in-person interview over 12 months to track the TB diagnosis and treatment status. Both self-report data from the participant as well as clinical data from the medical check reviews are used for this study. So as for the TBD regimen, there are two regimens. First regimen is isoniazid and rifampicin once weekly for 3 weeks. It's called 3HP. The other one is isoniazid preventive therapy IPT, which is daily isoniazid for 6 months, which called 6H regimen. For this analysis, I need to define the TBD completion definition. So when the follow-up data are recorded after initiation visit, based on the regimen. For the 6A regimen, if the participant having up to 2 follow-up visit, which is 6 months, and 1 follow-up visit, which is 3 months, for the 3HP were defined as the TBD completion, yes. But 3HP regimen become only available as a second option starting from the September 2023 during the study period. So regarding the variable selection, there were 2 binary outcome variable, TBD initiation and TBD completion. TBD regimen, employment, CD4 count, BMI, smoking, alcohol are used at exposure interest. And we also adjusted for the potential co-founders like access, education, enrollment size, housing, and merit status in the analysis. As for the data analysis, there are 5 steps. First, we use a DAG graph for identifying potential co-founder and discrete statistics for using the percentage and covariate analysis, univariate, multivariate regression modeling, and sensitivity analysis are conducted. The statistical method used was modified Poisson regression with the Sandwich estimator for the binary responses. And we use RStudio and Microsoft Excel for the software. And for the covariate analysis, 3 models are constructed, but based on the AIC score and adjusted R score, the final adjusted model controlling age, sex, employment, education, enrollment site, and housing types. So in terms of study overview, 96% of the per peer HIV are eligible for a TBT among the 411 enrolled, and 75 were initiated TBT and 25% were not initiated TBT. Interestingly, there is a stock out at clinic was one of the reasons for not initiated TBT. So among TBT initiated participants, 52 participants were unknown TB outcome. 33 participants are right sensor outcome, and then 19 participants are missing follow-up after initiation. Both TBD and unknown completion stated participants were removed from the final completion analysis, but followed by the sensitivity analysis by imputing the completion stated yes or no. Based on the TBD initiated participant with enough time to follow up, only 42% completed TBD. So as for discredited, 3HP regimens was 27% and 6H regimen was 73% among the TBD initiation. As looking for the correlate of initiation, there was significant association of the TBD initiation with the enrollment side and the employment. So as for the correlates of the TBD completion, only TBD regimen was a strong predictor for the completion, like other variable like employment, education, sex, and age show non-significant association. As for the finding highlight, so TBD initiation correlate, we found that the rural clinic had 21% higher initiation compared to the peri-urban side, which is consistent with the previous finding where the initiation was varied by facilities. And also the unemployed participant had 13% lower initiation compared to those who employ. Both factors are statistically significant in both adjusted and unadjusted model. And no other social demographic or clinical factor were associated with the initiation. And for the correlate of TBD completion, the shorter regimen, 3HP had a 58% higher completion rate compared to 6H regimen, which is statistically significant and also consistent with the previous findings. And also May had an unexpectedly 21% higher completion compared to female. And participant with the secondary and higher education has 32% lower completion compared to the primary education. But both findings are opposite to the previous finding. Interestingly, an employed client had 52% higher completion rate compared to those employed. We hypothesized that being employed may actually lower the chance of TBT initiation and completion because their work busy work schedule, and difficult to attend clinic appointment regularly. The other clinic factor, behavior systemic factor, not associated with completion. These are some limitations, but especially for the information bias and missing data bias, because like TBT completion outcome is mainly based on the Medicare chart review, which sometimes missing it of the data entry might present. So as a conclusion, TBT and initiation and completion is suboptimal. Less than half of the initiator completed like TBT. So initiation also associated with the facility type and employment from the finding. The shorter 3HP regimen has significantly better completion. Shorter patient-friendly TBT regimen are crucial for the improving TBT intervention. So regarding improving the TBT initiation and completion among the PL-HIV, targeted intervention like providing the 3HP regimen, supporting at-risk group like non-completion group like employed, female, higher educated, or patient may help improve TBT outcome. Besides equipping like her facility with resources and training for the TBT intervention. So lastly, I would like to thank all the study participants, the KwaZulu-Natal Department of Health, my thesis committee, Dr. Adrian and Dr. Xavier, and the DROP TB study team from the UW and Africa Health Research Institute, and my scholarship program and Department of Global Health, especially Dr. Tiber, who connected with me to Dr. Adrian, so making this journey possible. So thank you for listening to me. Here are the picture from the study site. Here's study nurse who performing the phone interview, patient chart review, and then taking sample from the clinic. And this one is the peri-urban clinic, crossing clinic, and this one is rural clinic of Kwandusi clinic. This area showing the housing and population of the rural area of the Kwandusi clinic, around Kwandusi clinic.
Yeah,
So
thank
here's
you
my
so much.
reference. Thank you.
Yeah, thanks, Pang. Nice job. Nice presentation. And wow, what a complex set of analyses and work that you've done. Really excited to see the finished product.
Thank you.
I don't see questions yet. So while people are formulating, I'm really curious. I know you really wanted to work in this area because back at home in Myanmar, you work in this area. So now that you've conducted this analysis of work done in South Africa, how do you think it would benefit you in your work at home in the same area in your future work?
Yeah, I'm used to work at the HIV clinic and have the same setting of limited setting. Basically, we base on the we don't have electronic like database. So I found that kind of result like interruption among people who are like having employment away from the clinic. So based on that, the study finding are consistent with not only my experience, also the previous research finding. So we need to, as a service provider, we need to focus on those people who are at risk of non-completion, like um, if they have if they require like higher education or like more awareness about the TBT benefits, something like that. My point is we need to focus on those participants. That will be my application from this study after doing that.
It makes sense. Thank you. Okay, so I see 2 hands raised. I think the first person is Sean Schreither. You can go ahead and ask.
Hello, thank you so much. First of all, wonderful presentation. I really enjoyed listening to what you've been working on and presenting these findings. I also thought it was really interesting that you mentioned that unemployed participants had higher TPT completion rates than those who were employed. So I was wondering if you had any insight or any speculations into why that might be.
Thank you, Shen, for the question. One possibility, like that I hypothesize that employee individual might have less flexibility to come pick up the medication, to come regularly follow appointment compared to an employee participant. So because like an employee participant might living around the clinic and have more flexibility to come follow up and have commitment on the treatment. And also, I think patient cost to come to the clinic is also affecting this area, this finding as well. But I think more data are needed to find in depth of why these finding are like that, especially with the qualitative approach, asking like the barrier of the both service provider and patient themselves, like their transportation costs, duration to come to the clinic, and their work schedule, something like that. So did I answer your question? Thank you.
Yeah,
That's perfect. Thank you.
we have 2 more questions, believe it or not. So I'm going to rush to try to call on Sai first, and then another question came in the Q&A and I put it in the chat. So if we run out of time, if you could answer in the chat, that would be great. But Sai, I believe you're first.
Yeah, thank you so much for the wonderful and interesting presentation, and really congratulate on this. And I have a question. Um, I'm just wondering, why did you choose to use the modifying Poisson regression with risk ratio for your binary response variable instead of more like commonly used logistic regression with odds ratio? I'm just wondering, why did you choose that?
Thank you, Sai. This is a good point there. Um, we use the modifying Poisson regression because like this study is based on common outcome, because like TPT outcome is completed or not complete is very common in this area. So but sometimes odd ratio using the logistic regression overestimate the risk, and also difficult to calculate the related risks from that directly. And also modifying Poisson regression using the sandwich estimator have like very, how can I say, appropriate adjusted for the standard error. So even though there is a violation regarding of the Poisson model distribution, like small sample size or like under dispersion in the data, this model have very appropriate with the consistent standard error estimate. So that's why we choose to use this method. But overall, because we want to give them the result which can easily interpretable compared to the odd ratio, that's why we try to and present the result with the risk ratio. That's why I choose this method. Thank you.
Yeah, thank you so much for explanation. Thanks.
Thank you.
Thank you so much, Peng. What a great job. There are 2 questions in the chat. If you have time to answer them there, that would be great. If you know the recipients of the answer, I can also email you the questions because you are the last presenter. So we had a few words, and we can keep it open for a while you answer, but I wanted to close the set of presentations for today and congratulate everyone for a job well done. These were the most amazing presentations that I've seen. Every year you top each other, and really nice, high quality work. So thank you everybody for putting together such great presentations. We have a number of presentations scheduled for tomorrow. So rejoin us there. Keshet Ronan will be moderating tomorrow. I wanted to thank all of the faculty who are on, who supported our students and presented and made this work happen alongside them, our supporters, fellow students, the family members that are here. Thank you so much for joining us today. I know we all couldn't do any of this without you, so thank you so much. And we look forward to seeing you tomorrow and then again at graduation. So very exciting. And like I said, we'll stay on for a bit so Peng can answer some of the questions that are in the chat, but we could also email them back.